Good afternoon to everybody who has joined, and welcome to all the participants. Today, we are here in solidarity to celebrate the World Patient Safety Day. That was a campaign that was started by WHO, the World Health Organization, and this is observed annually every year on 17th of September. So, the World Patient Safety Day is to raise awareness about patient safety and little things that we can do to make life healthier and safer for a lot of people in the world. So, the theme that was given this year by WHO is Act Now for Safe and Respectful Childbirth, or the theme is technically Safe Maternal and Newborn Care. For a lot of people, family is something that is happy, it's a happy news. And unfortunately, little things that can be avoided, simple measures, lead to the mortality of either the mother or the baby. The WHO campaign is to raise awareness about what can be done to prevent maternal mortality or fetal mortality. And by WHO, the Department of Life Sciences in Sophia College had decided to keep a 2-day event to celebrate and raise awareness. We have esteemed guest lecturers that are going to be there today and tomorrow. We are going to have a lecture by a gynecologist, a pediatrician, a reproductive research scientist, and a psychologist, because these are all elements that will lead to a safe and a happy delivery of the baby and safe for the mother. Let's hear directly a message from the WHO director and the regional manager.
This year's World Patient Safety Day on the 17th of September is dedicated to safe maternal and newborn care. Childbirth should be a time of celebration for families and communities. But for too many, it is a time of sorrow and grief. Every day, nearly 5,400 babies are stillborn, and more than 800 women and 6,700 newborns die mainly around the time of childbirth. These deaths are mostly avoidable with safe and quality care, delivered by skilled health professionals, supported by a strong health system. The Global Patient Safety Action Plan 2021 to 2030 provides strategic direction to eliminate avoidable harm in healthcare. WHO has also established a global network of partners for improving quality of care for maternal, newborn, and child health. To mark World Patient Safety Day every year, monuments around the world are lit up in orange as a show of global solidarity. This year, let's paint the world orange for safe maternal and newborn care. We call on all countries, health workers, communities, and partners to act now for safe and respectful childbirth.
It is my honor to address you on this special day. This topic should be close to all of us, not only because we all have been or will be patients of some kind, but because ensuring that patients receive the safest and highest quality of care is at the heart of our efforts to achieve universal health coverage. Patient safety is central to creating robust and resilient health systems where all people, regardless of background or socioeconomic status, can expect to receive safe and humane high quality care. This year's theme shows that patient safety is an area that covers the entire life cycle, starting with newborns and young mothers. In the WHO European region, we have made significant progress in recent years, with the maternal mortality rate having decreased by almost half between 2000 and 2015. But the numbers are still too high, and the deaths that still occur are for the part mostly avoidable. We need to act now, and there are three ways we can make a difference. First, we need to up our investments in health systems. Mothers and newborns need access to a range of quality postnatal services in hospitals, primary healthcare centers, and at home. Ensuring access isn't easy, but it can only come if we put the resources and the workforce where they are most needed. We know what needs to be done, we need to focus now on the how. Second, we need to refocus our attention on building a competent and resilient health workforce. We know that a qualified and trained doctor, midwife, or nurse can make the difference between life and death. But we need to make these professions attractive to young people entering the workforce, especially now in COVID-19 times. And this can only come with investment in the education and professional development of all health workers and appreciate them. Finally, and third, our European Programme of Work, EPW, provides a crucial opportunity for member states to listen to the needs of almost 1 billion people across the region and act for their health and well-being. The EPW calls for partnerships across key sectors in society, which also includes patient organizations advocating for better quality of care. Let's act now in partnership and solidarity for the safety of mothers and newborns everywhere.
I now invite Chelsea Romao, our PG student, to kindly take over the event.
Thank you so much, ma'am, for briefing us about the event. Good afternoon, everyone. I am Chelsea Ruma from MSc Part 1. It is my pleasure to welcome you here this afternoon and would like to thank you for joining us today for this special event as we celebrate the World Patient Safety Day, an initiative by the World Health Organization. Just a little bit of housekeeping before we get started. If you have any questions during the talk, please type them into the chat box. We'll bring them up after the talk is over. Please keep your mics muted and your videos off. Moving right along, I would like to call upon Tanisha to introduce our first guest speaker for today, that is Dr. Fazal Nabi.
Good afternoon, everyone. It is an honor to introduce the first speaker for today, Dr. Fazal Nabi. Dr. Nabi is an honorary consultant pediatrician, pediatric and neonatal intensivist, and is a specialist in pediatric and neonatal critical interventions procedures. He has over 15 years of experience in critical care and OPD, IPD, patient care, and has been involved in major pre-operative care of craniofacial surgery, cardiac surgery, and other general surgeries. Dr. Nabi is specialized in transporting critically ill pediatric and neonatal patients by air and land ambulance, and has managed an extreme preterm baby of about 24 weeks, 520 grams. Dr. Nabi has many international and national publications to his credit. He won a scholarship from the Har Gobind Foundation, Mumbai in 2001 for the fellowship in Pediatric Intensive Care, Leicester, United Kingdom. We at Sapphire are extremely honored to have you amongst us today. Thank you.
Thank you so much, Tanisha. I invite Dr. Fazal Nabi to kindly take over.
Hi. Yeah. Thank you very much for. Yeah. Can you? Is it audible?
Yes, sir, it's audible.
Yeah. Can yeah. I'm going to talk today about what is the newborn care. Okay, and we normal all other thing. Now, I wanted to you to understand what is the definition of newborn. Okay, can I have a next slide? Next slide, please. See, basically, if you see here, we consider under 22 weeks as a abortion. We can do medico-legally under 22 weeks. If you find something is wrong, majorly wrong with the fetus, which is not compatible with the life in future, we can take a call by doing antenatal diagnosis and terminate that pregnancy under 22 weeks. Once if we cross 22 weeks, it's a viable gestation. We can't do it. And perinatal period, what is the definition is 22 weeks to 7 days after birth. Neonatal period, it's up to 28 days. That means 4 weeks after birth. That is called neonatal period. Perinatal means just before natal and after delivery, that is natal. It's called perinatal, right from 22 weeks to 7 days after birth. Early neonate, again in neonates, we divide into two categories. Early neonate is first 7 days old baby, and the late neonate 7 days to next 3 weeks, that is 28 days of age. Next slide, please. And we classify them as per the gestational age. What is a full-term gestation is a 40 weeks, 37 weeks as per the definition. Total 9 months and 1 week pregnancy, it's a 40 weeks. Any pregnancy which crosses 37 weeks, it's a full-term baby, full gestational baby, up to 42 weeks. Anytime natural labor pain starts, anytime after 37 weeks to even up to 42 weeks. Preterm baby means under 37 weeks is called preterm. The preterm, again, you have a different categories, extreme premature, very low birth weight, that I'm going to come. Postterm means after 42 weeks. Means it's simple to remember between 37 weeks to 42 weeks is a normal full-term gestation. Before under 37 weeks and above 42 weeks is pre and post-term. Next slide, please. And we categorize newborn babies, even depends on the birth weight. Our standard Indian birth weight is 2.7 kilos till today. It is going up. Started with 2.4, now gone to 2.5, 2.7. Now it's like 2.8 is an average Indian standard birth weight of the babies. Normal birth weight is anywhere range between 2.5 to 4 kilos. Low birth weight, any weight under 2.5 kilos is a low. Very low is under 1500 grams. Extremely low is less than 1 kilo. Preemie, it's called preemie less than 750 grams. Micro preemie is 500 grams. This is by as per the weight record, we divide the categories. The reason for classification and division is the long-term prognosis of their weight, their outcome after delivery. Depends. Like 2.5 to 4 kilos bachus, they'll have a good long-term outcome because they are healthy, normal, full-term babies. And as lower the weight and more problems in long terms, learning disabilities and many other issues. Come on, next slide, please. Very low birth weight, as I said, it's less than 1500 grams. Next slide. Extreme low birth weight, yes, less than 1 kilo. Next slide. Yeah, preemie and micropreemie. Preemie means less than 750 and micropreemie is less than 500 grams. Very difficult, very fragile, difficult to maintain them on a nutrition because they can't digest. We have to put a lines, which goes into the heart and stays for a few weeks. And we have to give a nutrient supplements, including your major nutrients, macronutrients, and micronutrients like all electrolytes, fluids, calcium, magnesium, molybdenum, trace elements. Those things we have to calculate by minute to minute volume and supplement them till they matures. Okay, nowadays, previously in India, we used to support them after 28 weeks, 10 years down the line. And now we have advanced so much, and we support the babies after 500 grams. That means after 24 weeks of gestational age. So where the medical system has advanced so much, and we can keep the very micro preemies survive with a healthy, normal adult life. By advanced techniques, we have ventilators, we have a special nutrition for the babies. All that. Next slide, please. Now it's like coming to leave the preterm babies, now coming back to the normal babies. What is the components of newborn care? We say that's a newborn care, routine newborn care, take care. There are many advisors in India with all that different states and different policies, and everyone has a free advisors as soon as baby is delivered. Mom is always confused what to do. Everyone comes and give a free advices. From Malishwali Bai to Dhai delivery person, many deliveries happen in small remote villages at home. And their free advices, mom is always confused, and baby, they grow up and sometimes they'll end up with some lot of complications. Now, what is a comprehensive, what is a component of newborn babies? Just first thing is clean and safe delivery. As soon as baby is about to come into this world, you have to have a very clean and hygienic delivery. That's first we have to train many people. 1/3 of the deliveries in India happens at home, or otherwise half of the deliveries happen in the primary health centers. Maintain body temperature. As soon as they come out, different season, different weathers, especially in winter and monsoons, if you are not able to maintain, they have a low temperature damage. Like when you have a seasons that can damage the whole system, body metabolism. Skin care. You have to keep your hand clean and wash and then touch the baby. Care of the umbilical stump. It's a wet. The source of infection in newborn babies and everything is a umbilical stump. You have to cut it with the sterile scissors and apply a proper clamp, all that. Eye care. Sometimes they have eye discharge, control it, and there's a tear duct block, you have to massage. The most important, the backbone of your immunity, your development is a calories and immunity is from breastfeeding. Encourage mom to breastfeed. Weight record. Keep a record and give necessary advice, depends on the baby's weight gain. And the early detection of serious disorders. That means anything which is unusual than routine in a normal healthy newborn, immediately bring it notice to your treating physician. Vaccination is most important as per the national immunization schedule, and there's a many private vaccines. It's like we should do it to the newborn babies. And supplements and follow-up depends on the deficiency, whatever the diseases which reflects from the mom. Some moms have different gestational issues, diabetes, hypertension, and hypothyroidism, many other conditions which lingers in a mom can affect the baby's health. That's why the supplements which we had to give depends on the condition of the maternal and baby. Next slide, please. Clean and safe. Okay, see here, this is a delivering by cesarean. It's not a normal delivery. As soon as baby comes out from mom's womb, the stump umbilical supply blood continue to flow. As soon as baby comes out, then starts falling blood circulation from placenta, that is a mom's womb, to the fetus. We have to cut the clamp, and we have to cut the cord and clamp it. So as soon as you disconnect, baby takes independent life. Very important transitional life from fetal to external life, intrauterine to extrauterine life. This transition has to happen smoothly without any stress. That means keep the baby warm, covered, and let baby settle down, let baby expand the lung, breathe their first breath. As soon as you clamp and cut the cord, baby takes a first breath. All this it has to go smoothly. That's why that the transition time, clean and safe delivery. That's the same time If you use unsterile seizures and normal delivery or clamps, that can produce infection, and then the baby becomes worsening congenital condition on day 3, day 4. Okay, next slide, please. First 24 hours. As I said initially, as soon as baby comes out, you are taking care, and you are taking care of clamp and baby's temperature and wrapped and warm. What happens next 24 hours? Are very significant, highly vulnerable to critical transition from intrauterine. As I said, the major goal of nursing care of newborn infant is established and maintain homeostasis, stability in normal physiological status. And wiping. Head is a large surface area. As soon as baby is born, wipe the head, wipe the body, clamp the card, wrap the baby, and leave it alone. Don't try to clean even vernix. Vernix, what the white coated thing on the skin, is a protective vernix which protects the skin infection, or it acts as a barrier from outside germs entering into the skin. We try to clean, give a bath, which is not advisable. As per WHO and UNICEF, don't clean the vernix, don't give the bath first 2-3 days. Leave it, because that is a natural immunity skin barrier for the infections to prevent in a newborn babies. Next slide, please. Immediate basic care. As I said, maintain the temperature, establish the open airway whenever you are after the baby is born, and there's a lot of secretions. In mom's womb, inside uterine cavity, lungs are filled up with amniotic fluid. Oral cavity filled up with amniotic fluid. In a vaginal delivery, the chest gets squeezed, and all that amniotic fluid squeezed out, and lungs becomes dry as soon as baby takes a breath. In a cesarean section, baby comes out easily. Sometimes the wet lungs takes time to get dry. Till that time, they have little bit of wet lungs and fast breathing. So that's what we have to take care of. These wet lungs. Keep the neck position properly, and suction whatever fluid secretions which we see in the oral cavity, we can suck it out. And vitamin K we can give, inhalation of breast, and initiation of breastfeeding. As per the baby friendly hospital, as per the policy, as soon as baby is born in a normal delivery, we can keep the baby on a mommy's tummy. Baby can crawl to the breast and start suckling at the breast before clamping the cord. You can see that videos are available in Google's, and there's a beautiful, that's what we encourage in a normal delivery. As soon as baby is taken out, and keep a baby in a mommy's tummy, and baby starts crawling naturally towards the breast. That is called breast crawl. And baby starts sucking at the nipple, and this is a natural way. That's what we have to encourage. Amniotic fluid smell and mom's skin smell both are similar, and baby have that sense of security, because baby used to one smell whole 9 months. As soon as baby starts smelling mom's skin, baby understand, okay, this is my mom, by smelling. Next slide, please. Airway and breathing. As I said, in a baby, as soon as baby is born, clear the oral secretion first, then the nasal, not the nose first. Initially, you have to suck out. Okay, you have a central suction machine, you have a small suction machines, and this kind of suction with silicone balloon type, you can suck it out the mouth and then to the nose, not the first nose, because once if you start irritating the nose, then they can even aspirate that fluid into the lungs. Next slide, please. As a medical person, we see their APGAR score. Okay, APGAR stands for the appearance of the baby, that is a color, pulse, and grimace, and reflex irritability, activity, and plus respiration. These are, we give points up to 10 for each. How is the baby? 10 by 10 is normal APGAR score, and some babies almost after birth with a smooth normal delivery, they can reach anywhere above 8 is absolutely fine. We do APGAR scoring standard all over the world immediately at birth, that is at 1 minute after wiping and cleaning, and then repeat the APGAR scoring after 5 minutes. If baby has a good APGAR score, that means long-term outcome should be good. That's what that tells you about overall long-term outcome of the babies. Next slide, please. Maintenance of body temperature. As I said, warmth provided by keeping a baby dry with adequate clothing, and kangaroo caring, yes, which is encouraged kangaroo caring, as we can see in this movie, especially with the premature bachus. And bathing should be avoided first day to prevent hypothermia. Next slide, please. Skin care, yes, first, as I said, first 2 days, leave it with the vernix. Clean the blood, mucus, and meconium. No need to remove the vernix, and it provides a protection to delicate skin. Sponging is sufficient to avoid deep bath. Oil massage can be done before bathing. Next slide. Oil massage improves the circulation and muscle tone. And exposure to morning sun rays is an important source of vitamin D and warmth. The talcum powder should be applied over the axilla and groins buttocks. And always there is a controversy. Talcum powders is like a chemical dust. When you are applying, take it away from the baby, take it in your hand and apply lower half of the body. We don't need to use the talcum powders. Better to avoid. Sometimes if it goes to the nostril, it can block the nose, and it goes to the lungs, then child starts coughing and breathless. We don't encourage talcum powder. Oil massage, yes, we can give a smooth, gentle oil massage under supervision. Sometimes the malish boys are so rough and tough, and they do malish and with oil, and then thereafter at the end of massage, they put oil drops in the nose and ear, they squeeze the breast, the foreskin of the penis, they retract. All that starts troubling the baby. So overall, under supervision with a gentle massage is allowed. Otherwise, massage has no long-term benefits. It happens only in India. Abroad, those bachus who is delivered, they are also healthy, normal, strong enough as compared to Indian children. Next slide, please. Care of the umbilical stump. As I said, the source of infection at birth is a umbilical stump. Be careful. Apply a sterile clamp. Cut with the sterile scissors and take care. Clean the umbilical stump till it gets dry and falls off. Clean with a topical antiseptic solution, like even spirit, alcohol. Next slide, please. Eye care. Yes, clean using sterile cotton swabs. Any soft cloth, you can wipe the baby's eye. Separate swab for each eye. Application of kajal should be avoided to prevent lead poisoning. Kajal has a lead toxicity over a period of time. If you are applying kajals, one spot of front of the ear or behind, or sometimes occasionally it's all right, but not on regular basis, especially with the lower eyelid. Next slide, please. Breastfeeding and nutrition. The most important thing to have a good and better development is a breastfeeding. The baby should be breastfed within half an hour after birth. Colostrum feeding must be offered. Recommended exclusively breastfeeding up to 6 months to even 1 year. Mother should be informed about the importance of the techniques of the breastfeeding. Next slide, please. Varying stages of breast milk. See here, as soon as baby is delivered, it's a colostrum. What we get is a thick, transparent secretions. That's called colostrum. Colostrum has lots of protein and immunoglobulins that helps to build up your gut immunity and your body immunity. Transitional milk is a mix of colostrum and going into milk component. That is a transitional. And next is a mature milk. Mature milk means you have all components in that milk. And always keep in mind the fore milk and the hind milk. Why it's important? Fore milk is more of carbohydrate and little bit of proteins. The hind milk is more of fat and little bit of proteins. That means the fore milk is roughly, it's more of carbohydrates, and the middle milk has more of protein. The hind milk is lots of fat. All these three components baby gets if mom starts feeding one time one side. Next slide, please. Thick yellowish milk secreted in first 5 to 7 days after delivery. Rich in immunoglobulin, IgA, protects against infection and helps intestine to mature. Rich in vitamin A, colostrum, sodium, zinc, and plus chlorine, all that. Which is rich antimicrobial, lactoalbumin, lactate, ferrin. It has a lot of benefits. So do not miss colostrum. And if you start helping a baby by top milk after delivery, that's what it happens in many places, because baby is crying and mom doesn't get a support. Mom is antenatally not educated, not informed about the importance of breastfeeding. Mom is anxious, and attendants around mom-in-law and mom, they're also anxious. Baby is crying, we have to give top milk. Then we show the wrong path to the newborn babies. Instead of baby sucking at the breast, and baby start taking a top milk, which is an easy way of getting it, then thereafter baby never puts an effort to suckle at the breast. The most important is support the mom right from pregnancy, encourage the mom, and let her understand what happens in first 4 to 6 days after delivery. She has to be patient. She has to produce a milk by eating good healthy food. And plus, first 2 days, hardly few drops of colostrum, that's good enough. And the most important, the mom has to understand that baby doesn't need anything first 2 to 3 days. The reason being is before baby comes out from the mom's womb, mom pushes so much calories and energy into the baby's system, baby can sustain well for 2 to 3 days without a drop of milk. Next slide, please. And transition milk, as I said, colostrum is over, then transitional 4 to 7 days postmortem. And mature milk is produced approximately 10 days after delivery. Next slide. It is a major cation, sodium, potassium, calcium, magnesium. Iron low amount in percentage of absorption is high. Zinc, selenium, these are micronutrients. This is called trace elements, copper, nickel, and plus even molybdenum, manganese. These are all like a important trace element for any given child. Next slide, please. Technique of breastfeeding, very important. You have to learn, be comfortable yourself before you breastfeed the baby. Don't try to keep the baby comfortable. And before you think of holding a baby and everything, you plan wherever you are comfortable, you can sit or lie down and take a support for your elbows, and don't bend forward. Take the baby up, you take a backrest and touch the nipple to the baby's mouth. When baby widely opens the mouth, and part of the nipple has to be in baby's mouth. Part of the areola has to be in baby's mouth, because baby start suckling at the nipple, won't get any milk. At the end of 20-30 minutes, baby gets frustrated. After putting in a maximum effort, I'm not getting any milk. So that's why the positioning, baby has to latch on to the back portion called areola. Part of the areola has to be in baby's mouth. There are now endings, lactiferous ducts, which are situated in the areola. Once the baby starts suckling at the areola, baby can extract 95% of the mother's milk in first 5 to 6 minutes. Rest 5% milk, baby may continue to play and do and everything, spend another 20 minutes for that. But imagine 95% of the breast milk, which is accumulated last 2 to 3 hours compared as per last feed, 95% baby extract in first 5-6 minutes. That means the positioning is important. If baby is not getting a position, they continue to suckle at the breast for hours together. That's what it happens with the new moms. And we had to make them understand that positioning is important and mind relaxation is important. Next slide, please. Baby's body close to the mom, and baby is turned to mother. Whole body should be supported. The neck is straight or bent slightly back. Okay, so that's what chin, and between the chin and chest, there has to be gap, so that there is a proper position for a given child. Next slide, please. Position in breastfeeding. There are many things which we can tell you theoretical. The most practical is all moms, they go through their experience, they learn the best way of feeding the baby. Only they need a support from the family members and the pediatrician. If you go on encouraging them, they learn themselves. If you go on discouraging them, okay, there's a many comments which we see in a practice by family members. Shayad bachchu dubla dikh raha hai, he's not putting on weight, and hope he's not getting a adequate milk. We should give alternative. That all will start causing negative thinking in a mom, and then they start really having a milk flow suppression. I think encouraging a mom is most important from husband and family members. Next slide, please. Baby is still touching to the breast. Baby's mouth is widely open. Touch the nipple to the cheek when you're holding the baby. And when baby widely opens the mouth, put a nipple and part of the areola in baby's mouth. Okay, and you should not feel any pain. If you're feeling pain while baby is sucking, that means baby is putting an effort only to the nipple, not the areola. If you get a cracked nipple, that means you are not giving a right position to the newborn baby. Next slide, please. How do you judge? At the end of 1 month, when you go to pediatrician can weigh the baby and can tell you, okay, at the end of 1 month, your baby has put on 1 kilo. That means you are producing enough milk, and baby is getting enough milk and baby is digesting well. That is a story at the end of 30 days when you go for a vaccination. But our moms are restless, impatient. We need to help them so that they can continue to produce more and more milk. There's 4 ways of judging your milk flow is adequate or not on day-to-day basis, not at the end of 4 weeks. Day-to-day basis. That is, one is after breastfeeding, if baby sleeps for 2.5 hours, that means baby has got enough milk. And the second thing is, if baby start passing 6 to 8 times urine in 24 hours, that means baby has got enough fluids so that baby is emptying out through the urine. Third thing is if baby is regularly passing his stools, then you can observe the color of the stools. That is a golden yellow color stools. And the last most important factor is after breastfeeding, if mom feels that her breast is empty, that means baby has extracted good amount of milk. These are the factors good enough, okay, and to have an adequate milk production from the mom. And normal weight gain, we don't encourage the weighing scale at home because that unnecessarily depresses the mom. Normal weight gain is anywhere around 30 grams per day. Next slide, please. Sign of underfeeding. Okay, slow weight gain, decreased amount of urine, suckling of fish between the feet, sleeplessness, air swallowing colics, and hunger stools. Frequent small green stools is called hunger stools. So all these are very important. The next slide, please. Now, underfeeding we understood, then signs of overfeeding. Frequent regurgitation. That means is like in spite of having all negative reports, he'll continue to produce more hiccups and more regurgitation and lot of burping, all that. You have to relieve these by burping and holding, nothing else. We don't need to even stop breast milk. Next slide, please. Next slide. Now coming to express breast milk. Sick mom, local breast problems, preterm and sick baby, either maternal issues or preterm issues. Like preterm may not be able to suckle and extract with his low weight. That means mom has to express and give it. I express and how will you give it? If near-term babies after 34 weeks, we can try a direct what is spoon feeds. But in a preterm babies, we can't. We have to give through the tube. Okay, and sometimes issues are mom is producing, baby is not suckling. That also is a thing we have to take help of breast pumps and express and give it. Once if you express the breast milk, you can keep at room temperature for 8 to 10 hours, in the refrigerator for 24 hours, in a freezer up to 3 months. Next slide. Artificial feeding formulas. Only when mother is critically ill, mother is unavailable, mother is deceased, and that's enough. So these three, mother illness or mother is majorly on cancer drugs, we contraindicate the breast milk, then we have to give a top milk. Infant formula modified compared to breast milk. Here we are comparing the cow milk formula. Whatever you get in the market is a cow milk formula, a breast milk formula. 7% calories from the protein in a breast milk. Now, cow milk almost little bit higher, that is 9 to 12% calories from proteins. 38% from carbs, and here is 41% from the carbs. 55% calories from fats. And here we have almost similar 45, 50 calories from the fat. The major difference here is protein calories. Next slide, please. Cow milk during infancy, whole reduced fat or skim cow milk should not be used in infancy. Absolutely, when babies are growing, okay, we are arrested in our height, adults. Children are growing. First 1 year, they put on almost 25 centimeters. Okay, and otherwise 5 centimeters thereafter. After 3 years, we gain only 4 to 6 centimeters in a month. In a year. And here in a first baby who is just 1 month old, they continue to gain good height, whole fat. So what is required is a height is growing so well. That means they need more calories. More calories comes from the fat. So don't dilute. You don't need to have a reduced fat, skim fat, or that whole milk you can give. Iron deficiency is linked to early induction of corn milk. Yes, iron content in the breast milk, formula milk, cow's milk is high, is very low. Anemia linked to GA blood losses. Yes, sometimes we may continue to see a black color stools for weeks together. That also is contributed to food. Next slide, please. Soy protein-based formula during infancy should be limited to the use. It's usually not recommended. And plus, lactose-free and hydrolyzed formulas are better for infants under the breastfeeding, or to be fed cow's milk formula, or be fed the cow milk formula. We had to have these options. Next slide, please. Loose infants may make you for feeding readiness. Watching the blood, watching the food being opened in anticipation of eating, okay, that is not the sign of hunger. Okay, and a tight fist reaching for spoon is a one soft sign. Playing with a food or spoon, that also is a one soft sign. Showing of intake during away from full feeds. This also is a sign of that stomach is full. Stop eating and spitting out of is also a sign. Next slide, please. Introduction of solids. Okay, we have been talking about the perinatal period, antenatally, first few months, what is the skin, eye, and all that care. Now coming to solid food. Yes, the baby is a bottle-fed baby. Then start your complementary feeds, supplementary feeds, what we say, right from 4 months of age. If baby is on exclusively breastfeeding, putting on good weight, that means you can even extend the breast milk even up to 6 to 8 months, exclusively breastfeeding. Okay. Next slide, please. From cups. Yeah, you can introduce, right. This is not only for the mature full-term babies of different age group. It is also recommended with the small tiny cups for the kids to go to take liquidy food, whether juice or soups or milk through the cup. So they take it very well. Next. Improper positioning may cause choking, discomfort, and ear infections. Yeah. Position of the young bottle-fed infants as semi-upright in position. Spoon feeding should be with the infant seated with the back and feet supported. Adult feeding infant should be directly in front of patients making eye contact. Next slide, please. Food texture and development. Okay, can swallow proceed foods at 6 months of age, can swallow soft lumpy foods at 6 to 8 months and 8 to 10 months. Remember, when you start a milk, supplement, it has to be a pulpy, not the dal ka pani, patla soup, patla juice. That's the first point. And the second point, when baby grows, the food should become little granular, not the same consistency, thick, watery, soft, what you started at 6 months. And by 8-10 months, baby should eat soft mashed food. Whatever you cook at home, hand mashed soft food around 8 months of age. That's what we have to teach them. Next slide, please. Breast milk or formula feeds. Breast milk and formula provides adequate water help infants up to 6 months of age. Whatever breast milk you are giving, 80% is the water. You don't need to give an extra supplement of water unless until you start a solid food. All forms of fluid contribute to water intake. Additional plain water needed in hot and humid climates, and dehydration is common in infant. Next slide, please. Weight record. Assess daily weight gain 30 grams per day. Weight loss occurs during first 2 to 3 days, 5 to 8% of the body weight. With adequate breastfeeding, and majority of babies regain the birth weight at the end of 10 days. If mom is producing enough milk, baby has learned to extract milk. At the end of 2 weeks, baby comes back to or crosses the birth weight. That's what we wanted to tell you here. And they lose the body weight. That's what we have to alert the mom. Assess daily weight gain till they are in the hospital, not at home. Next slide, please. Detection of serious. Whenever patient comes for a vaccination and seeing the growth of the child, how his baby is doing, nutritional balance, food, all that. And same time, may you talk about some other condition which is rapid and bad conditions, so that they are prepared mentally, and same time we are prepared ourselves and to help him to pick up all that serious disorders in early phase. Next slide, please. Yeah, immunization. The most important, as I said, one is a nutrition, the second one is the immunization. BCG, hepatitis B, and oral polio. We have done. Okay, these are the vaccinations. In India, BCG, polio, and hepatitis B we give at birth. The reason is many patients may not turn up back for a vaccination. The TB is so common. BCG vaccine is given for a TB prevention. Don't assume that after taking BCG vaccine, we don't get a TB infection. Only after taking BCG vaccination, we are likely to have less severe infection. It's not like we cannot completely avoid getting it or stop coming getting it. It's not like any other vaccination. We can reduce the severity and the frequency of infections, especially TB infection. Many fatal childhood disorders can be prevented through vaccination, especially whooping cough, polio, TB, hepatitis B, which is 100% protection, and it also prevents the hepatic cancer later on at this stage. Mother should be informed about national immunization schedule and must know importance of complete immunization and possibly reactions following the vaccinations. Next slide, please. Supplements and follow-up. Each infant must be followed up but once every month, at least for 3 months, and subsequently 3 months interval until 1 year. And it is necessary to assessment of growth and development, early detection, immunization, management of the health problems. Harmful cultural practices should be discouraged. As I said, after massage, putting oil drops in the nose, squeezing of the breast, we should avoid. Okay, and putting earbuds in the nose and ears also we should avoid. We see accident coming up with the earbuds. And the third most important is the encouraging a mother's milk. Okay, and here it is necessary to assessment of growth and development. Any child who gets a good nutrition, they will have better growth and development, early detection, management, and health issues. Harmful cultural practices should be discouraged. Next slide, please. Harmful traditional practices for the care of the neonates. So use of unclean products such as drugs and umbilical cord, immediate bathing of baby after birth, use of pre-lactical feeds, installation of oil drops in ears, using a herbal water for bath, use of pacifier, and using a baby's breast to remove the milk, which I already discussed. The most important here to remove even pacifier. Anything? Somebody wants to ask me some questions? Okay. Now coming to harmful practices, even using a top milk also is your chance of infection is very high. Okay. Topical application of OPM brandy, no. Use of ready-made expensive formulas, no. Discarding of colostrum thinking it's unhygienic is absolutely wrong. Keeping a knife under the newborn's pillow, which matchbox under the baby's clothes to prevent baby from supernatural powers also is wrong. Branding therapeutic burns with a lot of iron and rods which can skin treatment of diseases like jaundice and next slide please. Next slide. Do infant need to be bathed every day? The fine bath of the baby every day if they enjoy. It is young babies who do not need a bath until they just set face mask and do I have enough breast milk to feed my baby? That's the most common question I ask. We in front of you babies around. I told you when baby sleeps well for 2.5-3 hours after breast milk. That's the one point that you are producing enough milk, baby is taking enough milk. The second point is if baby passing yellow color stools and frequent urine, that is a baby's got enough fluids to produce urine and passes 6 to 8 times in 24 hours is a normal. That means baby is getting adequate calories and milk. The third thing is mom feeling lighter breast after breastfeeding. That means baby has extracted good amount of milk. And the fourth one is most important. The fourth one is babies after taking feeds, relaxing, sleeping for 2.5 hours. Next slide, please. Does teething can cause fever? Many patients often told that teething can. The problem here is whenever there is a little low-grade inflammation in the teeth, so indirectly they are looks little more warm. When you record a temperature, we don't get temperature. So that is, and is any honey or dummy teething? No, absolutely we should not. Honey transmitted infection, especially botulism, that is ascending paralysis. That means they start getting paralysis, weakness, secondary to the jumps which comes to the honey. Next. Baby walker will help to walk sooner. Absolutely wrong. We should not use the walker because baby learn to walk and baby become more aggressive because he is different. Here he has support to walk around. Suddenly once we withdraw and they are very scared to even stand because that support has gone. That's why we don't encourage walkers at all. Holy thread around the baby's neck. That all these practices, sometimes this thread is so thin, it leaves a mark on the skin. Sometimes it will be entangled with the skin, or sometimes their own fingertips. We do see occasionally babies coming to casualty with excessive crying. Okay, we have seen the baby coming with a mom hair encircling the penis, causing a lot of swelling and pain. So see this kind of unmentioned problems we see in the practice. Next slide, please. Infants should be wrapped tightly or stayed to their legs. Answer is no. Leave them open. Just cover them. Let them move hand their limbs. Let them sense the free world. No wrapping tightly. Kajal should be applied on the eyes. Absolutely no. Already we have mentioned it is a lead toxicity. Okay, you can apply occasionally in front of the ear and behind, not on regular basis under the eye. Baby should not be taken outside the. Absolutely, baby should not be taken outside the dark. You should take out the baby, impress you, and baby can taken even in the daylight because baby has to get used to it. That's what they learn daylight and night. Otherwise, they come out from the dark world. Next slide, please. Dry powder is good for indigestion and colic. Newborn babies have a weak digestive system and only the good for their decades is tummies in their mother's milk. Many people believe that gripe water can be given them after a month. However, it is best to avoid the gripe water. Previously, we never used to encourage this gripe water, but now this gripe water is manufactured by the many standard companies with a standard protocol followed as per the laid down rule, depends on the country's BCJ regulations. I think if it is a simple ajwain water which is helping the child, we can use it, but carefully. Many brands are now not like previously. Okay, it's comes in with a good source. You can use this. Gram gram flour and turmeric powder, better soaps for a baby's dedicated skin. No, absolutely. Sometimes that can produce allergies. Then we have to avoid for a few months. So absolutely no. Next slides. Okay, coming. Now, what is important, what I wanted to convey here is most important is the breast milk. Encourage moms and so that they can have a healthy adult infant can grow into healthy adult. The incidence of diabetes, hypertension, and hypercholesterol levels, all these are now we categorize these disorders not an adult disorder. It is a childhood disorders with adult onset. That means the babies who are formula fed babies, babies who have a nutritional imbalance, all those babies, they slowly develop these disorders, but they manifest when they cross 40 years. So that's why name given for all these disorders are adult onset of childhood disorders. That means we have to take care right from beginning, not at later stage. Okay, so that's what we have to be careful, especially in a bachus. And the one point ahead of all this is prepare a mother during pregnancy time, antenatally, how to handle at labor room and how to take care of the newborn baby and what is the importance of the breastfeeding. That means antenatal classes, the gynecologist role and their family members role is so important to prepare a young mom to understand the process of labor, importance of breastfeeding, the most. That's what I wanted to convey. Any questions, please?
Yeah, thank you so much, Doctor. We will go ahead and take some time for questions now. Just a reminder, please sure to type your questions in the chat box.
Okay, sure.
Thank you so much for such an informative session. We shall now proceed to the questions, requesting the audience to kindly put down any questions you may have in the chat box. So our first question is, what happens if baby and mother blood types does not match?
Yeah, definitely. There is sometimes we have a different blood groups without incompatibility, especially ABO incompatibility and RH negative positive. When we have a RH negative mom with a positive baby, then there is a red blood cells starts breaking down. So we have to take care of right from beginning antenatally when we have this kind of RH negative moms, and we are prepared with an injection so that prevents the disastrous effect in the fetus, in the newborn babies. First baby is always escaped because mom produces an antibodies. That antibodies are circulating in a mom without troubling her. The same antibodies crosses the placenta during next second pregnancy and cause lot of trouble in the fetus. To dilute these antibodies, there is the injections available which dilutes the antibodies and then they don't have any reaction at all. That is called RH incompatibility. And ABO incompatibility is a simpler, easier, and we can handle it when the produce jaundice is a transient. We have an excellent treatment, only we need to be alert and take a appropriate right treatment at right time.
Okay, thank you, sir. Our next question is, how is COVID affecting neonatals? Are you still encourage mom and baby contact if supposed mom is positive? What about baby nutrition at this point?
Yeah, yeah. The standard recommendation is even if in spite of mom is positive test, we should not isolate the newborn baby. We should keep the baby along with the mom. The reason being, mom while breastfeeding and everything, she can wear a mask, she can wear a glove and breastfeed the baby, and keep the baby with her. And don't even give after breastfeeding, keeping a baby with a grandmom or sister. No, baby can carry that germs from mom to the other family members. Leave them alone, mom and baby in the room. Let them handle themselves. Let mom feed the baby. Importantly, why it's encouraged, because as soon as mom is gets infected, the anti-COVID antibodies, what she produce with the infection, that antibodies comes through the breast milk to the neonate, and newborn babies already they have ready-made immunity antibodies. Like post vaccination, you develop antibodies which already newborn gets it through the breast milk to the baby, so that even if baby gets an infection, it won't be so much severe because already baby has antibodies to fight with infection. Next question.
Okay, so next question is it dangerous for the baby if breastfeeding mother consumes alcohol or any medicinal drugs?
See, basically, uh, definitely all these narcotic drugs, we have a lot of fetal anomalies, especially when they consume, especially in first trimester. Avoid narcotic drugs. A lot of fetal anomalies in the first trimester or late trimester, the effects of the narcotics on the fetus, respiratory depression, sleepiness, drowsiness, all that. We don't encourage narcotic drugs at all.
Okay, so our next question is, you mentioned something about formula milk not being advised, but a lot of people say it is good substitute. So could you please elaborate on this?
See, formula milk is in a where you don't have enough mother's milk for some reason. Mom is like going through chronic illness. Mom is something medicine which we can't, like cancer drugs, or mom is on some organ illness like a kidney transplant or liver transplant or kidney diseases, where she is going through a lot of stress, so she may not be able to produce adequate milk for a newborn. That time we can supplement. But in a healthy mom who is delivering a 3.5 kilos baby, that means we can produce a good amount of milk. Only mom needs a uh, good support from their family members and their pediatrician. Because encourage the mom, let her eat well, let her rest well. As I said, all moms have enough milk to flow out. The four things are important. One is rest, one is positive thinking. The second thing is a positive encouragement with the family members. And the third thing is rest of mom. She can't expect to sleep 6 to 8 hours at night. We have to uh, uh, the rest as soon as baby goes to sleep. Baby doesn't know day and night. For 6 8 hours, mom can't take a continuous rest. Baby may demand every 2 hours. That's why we say that you have to change your lifestyle. As soon as baby is delivered, you have to change your lifestyle and adjust and sleep as soon as baby goes to sleep after breastfeeding. And the fourth factor is most important is nutrition. Lactating moms should not feel hunger at all. They should uh, eat before they feel hungry. Okay, that's where we can put it. Eat well so that we will continue to produce good nutrient milk. And the last most important is baby sucking at the breast. As much as baby starts suckling at the breast and extract the milk, that much amount of milk you are continue to produce more and more. Remember these 5 points so that encourage a mom to produce milk. Yes, in some rare factors, in spite of everything, then along with the mom's milk, we can give a supplements of formula feed. Next slide. Next question.
Okay, so there's another question in the chat box. What happens if mother produce more milk than what the infant consumes? Is this right, or does it cause any complication for the mother?
Yeah, sometimes if she's producing, if she's feeding, if her breast is becoming heavy and lumps formation, better to express, and she can preserve that milk. As one of the slides is mentioned, is you can preserve in the fridge for 3 months. Okay, and mom is resting or mom wants to rest, that time we can give that milk or later on up to 3 months, like anytime we can use that milk. And you can even donate to the breast milk banks. Okay, and definitely if milk starts accumulating in the breast, there is a lot of lumps happens, and the lumps will turn into infection abscesses. And then we may have to give an antibiotic and hot water baths to resolve that lumps, and sometimes even surgery to drain the pus. So first it happens when babies start learning and positioning is not proper, baby may not be able to extract because of wrong position, and mom continue to produce more and more milk, which starts accumulating in the breast. So we had to break this by giving a right position to the baby.
Sir, our next question is, what are the other reasons for the preemie or micro-preemie baby to be born other than prematurity?
Sorry, I'm not following.
So I'll repeat. What are the other reasons for a preemie or micro-preemie baby to be born other than prematurity?
Yeah, see, babies comes out from early. Naturally, it's like a mom starts having a labor pains only after 38, 39 weeks. Okay, and sometimes they start getting a labor pains. Okay, many reasons. When mom is infected, when mom has a vaginal infections that irritates the uterus and causes lot of moms has urinary tract infections can produce a premature labor pains. And these are the conditions, and sometimes these are fetal conditions. For some fetuses which are very heavy, and that also can produce for given gestational age, can produce premature. Some of the conditions may we say have maternal systemic disorders like uncontrolled diabetes, uncontrolled hypertension can produce premature labor pains. And other group of patients where we see a prematurity for some reason, for some infection or some metabolic or some inborn error of metabolism, whatever, many medical condition which starts compromising the fetal circulation. Means fetus is not getting enough adequate nutrition and blood supply from the placenta, and we come to know only by sonography. Once if you see sonography is showing his blood supply has significantly reduced to the fetus, means if you leave the fetus inside the mom's womb, we may lose in next few days or few hours. We may have to rush for a emergency cesarean to take out the baby and give a comfortable life outside the uterine cavity. So these conditions, that's why sonography Dopplers, what they do, Doppler tells you about the supplement, what is a blood supply to the fetus. So that's what gynecologists, they monitor and then they take a call. Okay, which happens in the especially IVF pregnancies. Premature labor pains is common in IVF pregnancies because IVF pregnancies are all supported artificially with lot of hormonal supplements and everything. Yeah, incidence of prematurity is seen in IVF pregnancy rather than natural conception, and incidence is seen in many maternal disorders, and incidence is seen in, for some reason, intrauterine infections to the fetus, intrauterine infection to the placenta or uterine cavity. Next question.
If you swaddle baby all the time, my elders saying that baby bones won't develop properly. So is this true or a myth?
Yeah, always swaddling is we don't encourage at all. Always cover the baby, let baby move hands and knees. That's the only movement baby has. Okay, no swaddling.
Okay, and next question is, mother having long-term diseases like diabetes or cancer, is there a high chance of passing it to the child?
Also, genetic based disorders now. Every disease is linked to genetic conditions. If there's a strong family history of diabetes in both parents, there's a 1/3 chances that baby is likely to develop a diabetes when baby is around later on in adult life.
Okay, sir. So there is one more question related to drug. Does drug addict mom really leads to drug addict babies?
No, not at all. No. Drug addiction is only the mom. The drug which comes through the placenta to the fetus, the newborn babies, and that the effect of the drug takes 3 to 7 days to rinse off from her body. Till that time, baby has that effect of the drug in neonatal period, but we can manage well and they come out of it.
Thank you, sir. Sir, another question is, why does the baby lose weight in the initial couple of days?
The baby has a lot of fluid retention in the body, lots of water content. Normally, all of us, we have 35 to 40% of total body water. Newborn babies, they have 70% of total body water. Okay, and that water content goes down. Once if they comes out, they start passing more and more urine. There a lot of water content goes down. That is required to go down. So once if it goes down, then that's why they lose weight in first 4 or 5 days, and up to 7 to 10% of their weight. And then they start gaining weight by getting a good nutrition from mother's milk.
And so another question is, what care should be given while pregnancy if the mother has PCOS?
See, basically, yeah, PCOS. Now, 40% of the females in urban cities are PCODs. Yes, because of our lifestyle. So only thing is you have to have a balanced diet. Before, not during pregnancy, before you plan to conceive, you have to balance your hormonal cycles. The most important. Okay, and consult your gynecologist. Take a balanced lifestyle, your stress levels, your resting pattern, and your eating habits. All this lifestyle is so important. The PCODs is common in urban cities. 40% adult females are PCODs. The reason is many factors. Lifestyle. The most common is lifestyle, and that's what any disorders, which is diabetes, hypertension, we say that diet control, salt control, sugar control, exercise, and all that. The most important now, before all this, what I said is the sleeping cycle rhythm. That means you need a rest. And the second most important, you need to have a good bowel habits. Your bowel movements should be good every day. If you don't have a bowel movements or constipation, that itself will makes you more discomfort, and it affects in each and every part of your other associated disorders.
Thank you so much, sir. Now we are done with the question answer session.
Thank you. Thank you very much.
Thank you so much, sir.
Giving an opportunity, but definitely whenever you require, I'm always. Thank you.
Thank you, sir.
Thank you, Arabia. Now I would like to call Jansi Binsali to propose the vote of thanks.
Good afternoon. We would like to express profound gratitude to our chief guest and resource person, Dr. Fazal Nabi, for having accepted our invitation and gracing today's seminar. We are extremely thankful and enlightened with your knowledge and presence. Some things that intrigued me and caught my attention during the talk was the intensive process of nursing and care after the newborn is welcomed to the world, the breast crawl, the APGAR score, the importance of colostrum, and the importance of breastfeeding. Thank you for your very interesting and thought-provoking address.
Thank you very much.
Thank you, Jansi. Now, without further ado, we will turn the time over to our next guest speaker. I would like to invite Tanishtha to introduce our second speaker for today, Dr. Himanshu Sinha.
Good afternoon, everyone. It is a great pleasure for me to introduce our second guest and speaker for today, Dr. Himanshu Sinha, a faculty at the Department of Biotechnology at IIT Madras. Dr. Sinha has completed his PhD from the University of Cambridge, UK, and has done his postdoctoral fellowships from Duke University Medical Center, USA, and European Molecular Biology Lab, Heidelberg, Germany. Dr. Himanshu Sinha is a population geneticist interested in how genetics, environment, and evolution dynamically modulates the information flow from genotype to phenotype. He works with these populations to develop transferable knowledge to understand complex human diseases. His lab works closely with the Center for Integrative Biology and Systems Medicine and Robert Bosch Center for Data Science and Artificial Intelligence to analyze complex relationships in clinical and genomics datasets to build models resulting in better clinical outcomes for improving public health. Today, Dr. Sinha will describe an ongoing public health project to develop India's first gestational age dating models for early and late trimesters. We extend our warm welcome to you, sir, and we are eagerly looking forward to seek guidance from today's talk.
Thank you, Tanishta, and thanks to Teresa for inviting me to this this interesting meeting. So I'll start sharing my presentation. Just give me 1 second. Just give me sit. Am I allowed to share? Is it? Okay.
Yes, I just please try again. I think.
Yeah, I got it. Yeah. Is the presentation visible now?
Yes.
It's in the presentation mode, right?
Yes, sir, we can see this.
Okay, great. Thanks very much. After listening to Dr. Nabi's talk, I think one of the questions that came up was for preemies and premature babies. So what I'm going to talk today about is a project that is funded by Department of Biotechnology called Garbhini. And I'll give you, in a minute, I'll give you the description for that. But before we proceed to the, I think Dr. Nabi might have already given some ideas about the total pregnancy. So, but I'll just go over very briefly to give the context of what my talk will be about. So what I'll do in this talk today is to describe how we are actually developing models for gestational age, which is the age of the fetus in the womb, and how do we estimate it accurately. And what are the current, so before doing that, I'll also describe what are the current problems that exist in dating these pregnancies and how these inaccurate or errors in dating can lead to sort of errors in the critical care that is required during pregnancy. So, okay. So why fetal dating or gestational dating is needed? So as you can see in this figure, that whole pregnancy is divided into 3 trimesters, first, second, and third. Embryogenesis happens in the first. Most of the development of the fetus or the organogenesis actually ends by the time first trimester is over or by the beginning of second trimester. And after that, it's just the growth of the fetus all along the second trimester and the third trimester. So essentially, what we expect in normal pregnancy to look like is that around by 40 weeks of gestation, the baby is born. That's an average normal age. That's an average age. Anytime a baby is born before 37 weeks, it's called preterm. And if the baby is born around 23 or 24 weeks, there's a 50% chance of survival. So it is very important to know the age of the baby, because if we do not know the age of the baby or the fetus in the womb, we will not be able to do several things. We will not be able to monitor and schedule prenatal care for the fetus. We will not be able to take decisions on when to do ultrasonography, which is a critical method of measuring the development of the baby. We will not be able to, as Dr. Nabi was mentioning, be able to give certain drugs, because in the first trimester, we cannot give certain drugs because most of the embryogenesis happens. After first trimester, some of those drugs can be given to the pregnant woman. So it is important to know the age of the baby. Secondly, if there is a change in maternal health, if there is a change in if there is a risk of abortion, or if there is a risk of congenital fetal development disorder, or if there is any in utero intervention that is to be done, we need to be very accurate about the dating that we are doing. And finally, because unlike any other disease where we have either the disease or not the disease, preterm is defined as a temporal thing. It is based on time rather than a appearance of any pathogenic feature. So for example, a baby that is born at 37 weeks or above is normal. Any baby that is born below 37 weeks is preterm. So how do we decide at the, let's say if some baby is born just before 37 weeks, is it preterm, or was the dating wrong that it is preterm, or it's born above a bit after 37 weeks, but actually it is younger than that, so it could be preterm, but we are terming it as normal. So all these decisions have to be taken care of, and these are what are called pregnancy outcomes. So given this is the case, it becomes very important for us to understand preterm birth and the chance of preterm birth happening in a woman. So why there is a need in India? In India, about 3.6 million babies are born preterm annually. And out of those, 300,000 or 3 lakh babies die soon after birth. So there's a huge burden on the parents who suffer this loss, and all the health system, because there are a lot of interventions that are required for caring these babies. And unfortunately, India contributes to about 25% of the global preterm deaths. So this is when we compare this to WHO goals of lowering the childhood mortality. Preterm birth actually contributes a huge chunk of it, apart from childhood and neonatal diseases like diarrhea and all. And even the ones that survive, they have long-term consequences where they could be, because of the fact that their organs were not fully developed, they could have hearing and vision disabilities, some cognitive defects, especially they can have lung diseases and other complex diseases like hypertension and diabetes. So it becomes very important for us to understand this kind of high rate of preterm birth in India. And as you can see in this world map, India is shaded darker than some of the countries in sub-Saharan Africa, which is quite surprising, because in sub-Saharan Africa, the average rate is around 7 to 8% preterm birth. We have an average rate of around 13 to 14% preterm birth. So this is something that is very, very unique about India, and this was one of the reasons why Department of Biotechnology in 2015 initiated a project called Garbhini Cohort, which is executed by an institute in Faridabad, Haryana, Translational Health Sciences Technology Institute. And this is a observational cohort. That means we are observing women who are pregnant and following them throughout their pregnancy. This cohort is being run at Gurugram Civil Hospital in Haryana, and this civil hospital covers about 750 square kilometer area around the city. And in this cohort, we have enrolled 8,000 pregnant women. So I'll just briefly, so Gurgaon is sort of north of India. So I'll just briefly give you what the cohort is like, what is this observational study. So we try to enroll women who are pregnant in their first trimester, either between less than 11 to 14 weeks when their first visit is determined, or definitely by the time they are starting their second trimester. So when they first enroll, we collect several biospecimens. These biospecimens include blood, saliva, feces, high vaginal swabs, urine, placental tissue if later on, not right away, an umbilical cord later on again, and neonatal heel prick also once the birth is done. But initially, we just do blood, saliva, and feces and high vaginal swabs. We also do an ultrasound at that time to determine the age of the baby. Then, or if they do this first visit, then it's done once. Then if they are enrolled early, there would be a second visit where there would be another biospecimens collection and another ultrasound. But if they are enrolled in the second scenario, this is the only scan that they get. This is because they are not enrolled in the first scenario. In the second trimester, which is this period, they get only biospecimens, and in the fourth, between 28 and 32 weeks, they get one or two, depending on the requirement, one for sure, maybe 2 ultrasound scans. And then we also ensure that the delivery happens at the civil hospital, so that we can measure all the neonatal parameters, as well as the kind of delivery, whether it's a C-section or a normal delivery. And also we can age whether it's a preterm or not. And then a visit is done 6 months postpartum after delivery, 6 months after delivery at the house of the woman. So this is the sort of the enrollment strategy. Most of the women are enrolled in the first trimester. All of the women these 8,000 women were enrolled in either scenario 1 or scenario 2. Apart from this, we also collect a lot of different data. So we collect a lot of socioeconomic data, which includes maternal age, education, occupation, socioeconomic status, smoking, alcohol intake. As I said, we all anyway are doing ultrasound. So ultrasound would give us gestational age, early morphology, anomaly scans, fetal well-being scans. We also collect obstetric details from the woman, the mother. How much is the interpregnancy interval? That means if this is the first child, or if there was another child, how long ago was that? Whether there is a history of any prior preterm birth, what is the age of marriage, what was the time of first delivery, first pregnancy, if this is a second child. And then we collect several clinical features, which includes anthropometry, which is the height, weight, BMI, waist, hip ratio, blood pressure, hemoglobin, vaginal culture, urine, and albumin. So all the standard blood characteristics. So for every woman over the period of 9 months, we are collecting around 1,300 features, data points, in which includes all of these. So if you now multiply this by 8,000 women, so ultimately we have 10 million data points. And this is a very high quality data with high accuracy and completeness, because this is a cohort that is, so just to give you an idea, to enroll 8,000 women, we had to screen 30,000 women. So out of 30,000 women, we are only using the data for 8,000 women. So this is why this has very high level of completeness. One of the challenges in doing any data analysis of clinical data is the data completeness and data accuracy. And fortunately for us here, we have a data which is both high quality and with high accuracy and completeness. So I'll split the talk into two sections. One is how do we date in the first trimester, because that's slightly different than how we date in the second or third trimester. So how do we do the dating in first trimester? First trimester, as I said, it's mostly embryogenesis and organogenesis. The baby is not fully formed. There's if one does an ultrasound scan, whether it's above on the abdomen, over the abdomen, or vaginal scan, it usually will give an image like this, which would be a dark circle with a contour of a baby. And first trimester is from 0 to 13 weeks. Here we calculate only one feature in the ultrasound, which is called crown, which is the head, rump, which is the butt, crown rump length, CRL. Okay. So gestational age of the baby can be measured by two means. One, by knowing what is the date of last menstrual period, or LMP. Because if you look at this figure, the last menstruation is considered as 0 time point. Fertilization happens in 2 weeks, so 14 days. So if you know your last menstrual period, you can add 14 days to it, and that would be the start of the embryogenesis. That's when the fertilization happened, and that's from where you actually start calculating the date, the age of the baby. So last menstrual period, or LMP, is a very important data point for us. However, if you consider last menstrual period, it is a recall-based data. Recall-based data means you have to ask a woman, when was your last menstruation? If they have been tracking their menstrual cycle, they will know very exactly. But usually, if you consider in rural or semi-urban setting, they might not know their last menstrual period date accurately. So there is some scope of error in LMP, but we'll come to that later. The second is using this ultrasound method where we measure the CRL, and we have a formula which we can apply and know the gestational age in weeks. Okay. And this is just to show, this is an ultrasound machine. The ultrasound machines that are used in India, it's so most of the women would go to a radiologist or a hospital. They would go and the radiologist will do an ultrasound scan, and then and there they would actually give the parents the expected date of delivery. Now, this date of delivery is done by the machine automatically, because when the machine is given the value of the CRL in centimeters, it will tell the age of the fetus and automatically then give the date of delivery, because the current date is already input in the date of scan is already input in the machine. Now, the problem with this method is that these machines actually have a formula from which was developed by a scientist called named Hadlock in 1992, and this is the paper, where he developed this formula to calculate gestational age or the age of the fetus using white Caucasian US women. Now, if you consider the differences between Indian population and US population, you can very well appreciate that there can be differences in the way these white Caucasian women would have had their nutrition, LMP, and all those things measured very accurately, whereas we are going to use the same formula on women who may not have all the facilities, especially in the rural settings. So this is the problem. And therefore, we actually went ahead and compared the first trimester dating method, which is the Hadlock method, and developed our own Indian formula using the Gervini cohort. And this paper was published in April this year. Okay, so this is the Hadlock formula, which is already input in the machine. Given that this is the only formula that is input in the machine, several other countries around the world have developed their own formulae. So Australia has their own formula, UK has their own formula, China also has their own formula, Netherlands has their own formula. And then there is a very recent formula from a cohort study called Intergrowth, which was funded by WHO, where multiple populations, including a small population from Nagpur, India, was also included. So you can see these are all like polynomial formula using CRL as one of the only feature. What this means is that right now we don't have any published formula from India, and that was one of the first challenges we wanted to tackle. Because if we cannot date the pregnancy accurately, we would not be able to tell accurately whether the baby is preterm or normal term, and that can be a problem if we want to do any interventions regarding preterm birth. Okay, so how did we go about doing that? First thing we did was we had the Hadlock formula. We knew from the ultrasound machine what is the gestation age given, and we knew from many women we came to know what their last menstrual period date was, and we compared the difference between what the ultrasound machine was telling us and what their memory was telling us. So if you can see, this is a distribution. This is sort of what is called a Gaussian distribution or normal bell curve with an average around 0. That means for majority of the women, around like 600 women, there was no difference. They accurately remembered their last menstrual period, and the ultrasound machine was also accurately telling the same gestational age. But if you can see around this side, on the left side, this is difference in days. So see, there is almost like 1 week to almost 2 week difference between what the machine is telling and what the woman is telling, right? So that means if the age here for these babies, the age is getting underestimated by almost 2 weeks, which is a huge difference, because if the baby is term, we are going to call it, if the baby is born in the normal term, we are going to call it -2 weeks. That means we will term that baby as preterm. And that would be a problem, because then if the baby is preterm, then a lot of other interventions start happening to the baby, right? And similarly, there are babies which are actually overestimated. That means they are older than what the machine is telling. So both the scenarios are problem in one way or the other. So this was the kind of difference we were seeing, and we wanted to reconcile these differences. So one of the first things we did was we plotted the gestational age based on Hadlock. Whenever I say Hadlock, that means from the ultrasound machine, and LMP when we compared these two gestational ages. So this on the y-axis is the gestational age based on Hadlock minus the gestational age based on LMP. So 0 means no difference. 5 days, 5 days, 10 days, right? And on the other side is the mean. So if I calculate the mean, so you can see these individuals on the top and these individuals on the bottom are the ones that will have an inaccurate gestational age determination, because they are not, there is no reconcilement between what the woman is telling and what the machine is telling. Now, as I was saying, that LMP can be unreliable because of several reasons. One of the reasons is memory, right? A woman may not remember the last menstrual period, but there are other clinical issues that can change the LMP. So, for example, there was somebody asked about PCOS. If a woman has PCOS, she would have irregular periods, so there would be it would be an unreliable last menstrual period, because the length of the period would not be 28 days, but it would be variable. So because reliable LMP can be unreliable, we had to sort of figure out whether LMP, if we remove the erroneous data points, does it really change the way CRL based estimation of gestational age changes? We found that it really did not, because majority of the data actually lies within this gray zone. And that is one of the very important things, because the accuracy and the quality of the data is so high that we can just take this about 90% of the data and be still very accurate about calculating the gestational age. Okay, so whenever you do these clinical studies, you have to actually generate data. You have to actually filter a lot of data. So we start, for example, in this case, we started around with 3,500 women participants. We excluded almost about half of the participants. And this is a very important lesson, right? Good data means if somebody doesn't have good data, they need not include that data every time, because they have just done so much effort in getting that data, right? So we almost remove half of the participants because they had no CRL measurement, for example. They had multi-fetal pregnancy. So whenever there are twins, there can be challenges with the growth of the fetus because of the limited space. So most multi-fetal pregnancies are high risk for preterm birth, or in some cases, abortions happen after the first scan was done. Then, so we are only taking singleton births. That means only one fetus is there. Then we excluded all the measurements in which the radiologist could have made error, where we know for sure that within the first trimester, the CRL value cannot be more than 10 centimeters or cannot be a negative value. So this could be a data recording error, and we removed that as well. And we also know that gestational age cannot be 0 and cannot be more than 45 weeks, because that's the outer limit of human pregnancy. So we removed those. They were just 2 and 3 sample participants like that. So ultimately, we had a data set with permissible CRL values and GA values, which was 1,721 participants. because several of these participants, as I mentioned, can have 2 scans in the first trimester. So total number of scans were 2,500. We split that data into 2. One was where we filtered the data based on the clinical parameters. That means no smoking, no chewing tobacco, no drinking alcohol, or there are smokers in the house, like husband smokes or somebody else smokes in the house, BMI greater than 25 or less than 18.5, which is beyond the normal BMI range, assisted conception, because that would mean that they had trouble in getting pregnant naturally. They were breastfeeding. If they were breastfeeding, that means they would have again irregular period, or they were using contraception and they got pregnant, because once you're taking pills, it takes some time, a couple of months before the cycle gets back to normal. So we excluded all those and created a smaller data set of 650 participants. And then we used a mathematical model. The other one was from the same data set. We did a mathematical modeling to derive a data set which was quite large, almost more than double the clinical filter data set. So this is clinically filtered data set. So if you look along, so the black points, if you can observe, the black points are actually spread all over the place, right? They're concentrated in the middle, but they're also here. And we know that this is the range in which all of the points should lie. So all these points that are beyond the range include, which are considered to be clinically okay samples, women, but also include which are clinically not okay, right? So that's a problem. So whenever you have a data which is noisy, it becomes harder to make an accurate prediction. So clinical parameter based filtering was very noisy. However, when we use a mathematical model, which is called DB-scan, it just gave us only the data points that were around this light gray line that you can see in the middle, right? So that was a more uniformly clustered data set. Okay, so as I said, for each woman, we were measuring a lot of different parameters. So so how do you select which parameter is important? So one of the ways to do that is to actually use, again, mathematical models or machine learning methods. And there were 2 methods we used. So crown rump length, which I said was CRL, was one of the features. BMI of mother becomes an important feature. The current weight of mother also is an important feature. Abdominal girth, which is at the first trimester, and age of the mother. And a sort of something that came up as a spurious feature was state of residence in India. Now, that is something which is very strange. In the other model that we did, there were only 2 features: crown rump length, which is common among the both, and education of the mother. So both of these, so what we did, we took both of these lists, merged them together, and we did what is called brute force model selection, which is we take CRL normally, or we take log value of CRL or square root of CRL, and or weight, which is the current weight of mother, log of that. So for each of the feature that is listed here, we have 3 methods of transforming the data: either exactly the same data, log of that data, or square root of that data. Now you can see that's common across all. So now if you take all of this and do all possible combinations, and then form 4 different kinds of equations, this is about 1400 different equations. For 1400 different equations, we did what is called 1000 times we did that calculation. And what we found was very clearly the only feature that is required to measure gestational age is CRL. None of the other features actually matter. And that was sort of a validation of our analysis, because we also know that CRL is only the feature that is required in the first trimester. So this figure shows that whenever CRL was present in the formula, the value was close to 1. Whenever it was absent, so whenever this feature was absent, the value was close to 0. Okay, so then we had to figure out whether it's a linear equation, whether it's a quadratic equation, or whether it's a polynomial equation, right? So degree 1 is linear, degree 2 is quadratic, degree 3 is polynomial. And as you can see here, we are ignore clinical filtering of the data, clinically filtered data, but just look at the DB scan filtering. When it's a linear equation, the error in measuring the gestational age. So error can be anywhere between 0 and 1. When the error is 0, that means it is error can be anywhere between 1 and 100. So when because this is a square value, it's called RMSE, root mean square error. So when the error is small, the equation makes prediction more accurately. When the error is large, the equation makes errors more, right? So if you look at the linear, that's 8.852. If you look at quadratic, it's 0.813. There's a slight change, but it's a significant change, and it doesn't change when you do it to the polynomial. So we stuck to this quadratic equation, and this became our formula. So this is called Garbini 1 GA formula, gestational age formula for trimester 1, which is a quadratic equation, which is with only CRL. And as you can see, this is square. This is, so it's like A square plus B plus C, right? So AX square plus BX plus C, that's what the formula is. And you can see this is the estimation of error using our formula, which is Garbini 1 formula, GA1, just an error on this, and the Hadlock formula. So now, if you can see this still, if all the formula were accurately measuring, they would all lie at the 0 axis. But you can see for some of these formulae, including ours, there's some error at one of the ends, which is fine. So what it means is that all of the formula, whether it's the Garbini formula or the Hadlock or any other formula that I mentioned early on, they all perform equally well, regardless of what the what the formula is. So all of the formula perform equally well. But one of the things that this formula actually does better in, Garbini 1 formula better in, is it has the lowest preterm birth rate estimation. So this is your Hadlock formula. This is your LMP, last menstrual period. So if you just take last menstrual period as a parameter and you estimate what is the preterm birth rate, it comes to around 15%. This is the average, 15%. If you take Hadlock based calculation, that value comes to around 16, 17%. But if you take our formula, which is Garbini GA1 formula, that comes to around 11 point some percent, right? And what is the reason for that? The reason for that is shown in this figure, where you can see what happens is that these two lines with the two dashed lines that you see, this is 37 weeks when GA is estimated by LMP. This is 37 weeks when GA is estimated by Hadlock. The babies that are in this, the babies that are blue dot, are the participants that are blue dots, are the participants that are purple dots, are the ones that are inaccurately measured by both LMP and GA, by Hadlock. And we, using Garbini 1 formula, can measure them more accurately and put them either here, which is normal term, or put them here, which is preterm, right? So by accurately estimating the erroneous values that come because of LMP or Hadlock, we are able to actually predict the preterm birth more accurately. And this is, while this is a drop of, if I were, this is because this is the Hadlock formula, is the ultrasound machine formula. So if you look at it, it goes down from 16% to around 11%. So 5% decrease, which is a huge decrease given that India's population is large. So 5% decrease in preterm birth estimation can have a huge effect on the public health outcomes, on the health outcomes of the baby, neonatal baby, and on the health outcomes, on the financial outcomes for a family, right? So that's the challenge. So what were the key observations for first trimester? We developed this formula, which is called Garbini 1, GA1. It performs comparably to other formula, but has the highest sensitivity and accuracy in classifying preterm birth. No other clinical or socioeconomic features actually affect the accuracy of first trimester dating. But what happens in India is that, and low and middle income countries like India, is that for most women, the first visit to the hospital during pregnancy happens in the second trimester only. Most women actually do not know they are pregnant till about 6 to 8 weeks when they miss their second period. And by the time they realize, they are already in their second trimester. So for 40%, approximately 40% of the women, the first visit to hospital is around second trimester. And when a pregnant woman visits the hospital in the second trimester, CRL is not a measurement, because by the second trimester, whole of the organogenesis is done. And then comes 5 different kinds of ultrasound features that need to be measured, along with 2 other features. One is the head is fully formed by that time. So you can actually measure the skull. So this is the skull of the baby, the largest circumference, and the OFD is the largest diameter, BPD is the smaller diameter. So this is an ellipse. You can measure 3 parameters from the head itself. Then you can measure what is called abdominal circumference, which is the circumference of the abdominal region. And you can also measure the first bone that gets sort of ossified, the femur, which is the longest thigh, which is a thigh bone, which is also called femur length, right? So from second trimester onwards, these are the 5 features that are measured by a radiologist. So it's not going to be a simple formula which only has one parameter like CRL, but it has to be a complex formula which includes all these 5 features. There are 2 other features that we measured. One is called symphyofundal height, which is the height, the distance between top of the uterus to the pubic bone. So that is the sort of estimation of the growth of the baby. And because we know, and I think it was mentioned again in the talk, that cervix is where the plug happens. So if the length of the cervix is small, the risk of preterm is high. So it is important to also measure cervical length of the uterus of a pregnant mother, right? So these are the 5 plus 2 parameters that we measured for every woman coming after second trimester. One of the advantages we had in this cohort was that for the first, all the women that we considered in the second trimester, we had already dated them in the first trimester. So GA, gestation age, was done using crown rump length. We applied the Garbani GA1 formula. We got the first trimester gestational age. We added the difference between the first trimester date scan and the second trimester date scan, the difference here to this gestational age, to get the gestational age predicted by the first trimester data at the time of the second trimester scan. So this is what is called the gold standard. The reason first trimester dating scan is considered gold standard is because CRL is a very accurate measurement of, has the highest accuracy of measurement of gestational age, because it's a very simple feature. It's just the length of the head to butt. That's it. So it is a very high accuracy. Later stages, what happens, like if you look at these things, for example, abdominal circumference depends on maternal nutrition. So if the mother is having insufficient nutrition, abdominal circumference can shrink. And this leads to developmental defects. The baby's weight could be smaller. So the overall femur length could be different. So all these other things start happening. So till first trimester, mother's nutrition, even though it's important, it does not really change the way CRL changes. But after first trimester, in the second and third trimesters, mother's nutrition, be it overnutrition or undernutrition, critically and significantly affects the development of the baby. So therefore, gold standard is mostly considered from the first trimester date scan. Okay, again, data selection. So here we had a larger number of women enrolled, 6,500 women. We excluded again half of the women because half of the women did not have a CRL scan. That means they enrolled first time in the beginning of the second trimester. We excluded again multifetal pregnancies, abortions, and stillbirths. At the end, we were around like 2,650 participants. We split the data into 2. We did not do clinical filtering and DB scan here because it's not a single feature that we are measuring against. We are measuring against 7 different features. So it is not possible for us to do the kind of work that we did for the first trimester. But we did something very more complex than that. Again, so we did feature selection. We asked the mathematical model or machine learning model, what are the features that are important for dating a fetus in second trimester. And as you can see, biparietal diameter, head circumference, occipital frontal diameter, so BD, CHC, and OFD. These are the head features, abdominal circumference, femur length. These were the common features between both of the two models that we used. Femur length also came as a common model. Symphyofundal height, SFH, again came. Cervical length also came. Another feature that came was blood pressure. And then in one of the model, we also got pulse pressure, mean arterial pressure, and systolic blood pressure of the mother. So all these features were combined, and we then asked, using another model, of these so many features, which are the most important features. And as you can see, the importance is on the y-axis. These 5 features are the most important features, which are the head, 3 head circumference, 3 head features, and 1 femur length and abdominal parameter. Then comes the current weight, abdominal girth, that means the waist height, waist ratio, BMI. These were the only features that were important. After this, nothing really mattered. Not hemoglobin, not family income, or cooking fuel, or diastolic blood pressure. None of these mattered, right? So only these 9 features were most important. So now, because there were so many features, it becomes very hard to develop a model. Even with 5 ultrasound features, it becomes very hard. So in this case, we actually tried doing polynomial regression, which is brute force modeling. We developed 104 formulae from these 5 features, and the error values ranged very low. They were 0.136 to 0.137. So this was not really very good. We then applied what is called a neural network. This is a machine learning method. So you give the input data, there is an algorithm which runs on the compute input data, develops these what are called hidden layers, and then classifies or gives an output layer. This was done, but it was quite accurate. Only thing was that we were getting a very sort of an average amount of what is called R square value, which is around 0.7, which is okay, which is not that great. Then we finally did another machine learning method, which is called random forest, in which it sort of works as so what you do, you randomly split the data into multiple points, and you ask the computer to actually figure out what are all the possible paths it can take. So it's like a random forest walk. So if you go to, like in Mumbai, you have the Sanjay Gandhi National Park, right? If you go randomly, not follow a trail, and you try to reach a particular destination inside the forest, what are all possible paths you can take, right? Or what is the shortest path you can take? Ultimately, what would happen is that if 10,000 students go from the college, do this exercise, there would be one particular path which would be called majority path, where everybody would have gone through that path, and that path will become what is called a Pagdandi, right? You will be like having that. So that's exactly what we did. So we took these 5 features and we split them into these sort of randomly, and we asked what is the most common way by which you can accurately predict the gestation age, right? In this, there were 11 input variables, but only 5 were most important. So I won't go into the details of how this is done, but this is essentially what it is. So now, again, we are giving the error in GA estimation. This is in weeks now. So if you see, this is our model was called Garbini GA2 for the second trimester or third trimester. So Garbini GA2 is this blue. So if you look at the center of this is the peak of the formula, that's around 0. That means it has the highest accuracy. Now, gestational age estimated by the formula compared to the gold standard. The gold standard, I said, was from the first trimester. So how different is our formula predicting from what the gold standard formula is predicting, gold standard data is? Garbhini 2, GA2 had the highest accuracy because it had the least error. Hadlock, which is also input in the data in the machine, has the highest error because if you can see the peak is already shifted towards the left. That means it's underestimating the age of the fetus, even though the fetus is equal to the gold standard. It is saying it's almost like 1 week smaller, right? And it can go up to like 5-6 weeks smaller. So the error on Hadlock was very high compared to the random forest model, which is 0.89. Okay. And this is the sort of we what we do is what is called model performance. So the red line indicates the model. So this is the Hadlock model. And you can see for all of these are various participant data points. And you can see actually the line does not pass through the data. All of the data actually lies below the line, right? This is another formula. Forget about this. This is our formula. And as you can see, the formula and the line actually passes through the middle of the data, which means that this model is going to be more accurate than this model. And this is what we are already seeing, that it's trying to underestimate the age of the fetus, even though the fetus is of a particular age. Let's say it's 22, it's saying it's 21. And this has a huge effect on preterm birth prediction. So when we predict the preterm birth basis the gold standard, that means using the gestational age from the first trimester, the preterm birth of the data was around 9%. Our GA2 formula predicts it around 10.5%. Hadlock predicts it around 22%. Huge difference in terms of what Hadlock is going to classify. It's going to classify almost 12% of the babies as preterm, which actually are not preterm. And this is something that can make a huge difference in the public health, right? And the reason is that this is the way. So as I said, this is preterm according to the gold standard. This is preterm according to the Garbhini GA2 formula. Very few dots. You can see very few dots here, very few dots here. Look at what Hadlock does. All these orange dots are actually preterm that are determined by Hadlock. So a lot of these babies are actually not preterm, but they are being classified as preterm by Hadlock. And this is a big problem with the current model, that is a standard model in the ultrasound machines of almost all radiology centers around India. So this makes a very challenging problem for us, right? We are trying to reduce what we are trying to do by developing these formulae is to actually tell that please stop using the formulae that are used in the machine. Use something which has been developed for India, for using Indian data, using pregnant women from India, rather than something that was developed in US. And this would be more accurate because Indian population is very unique and very different from US population. So what is I haven't told about what is the ultimate goal of Garbhini cohort study. First is to predict whether a woman is high risk for preterm birth or not. And if we can do early, either in first trimester or second trimester, a doctor, a gynecologist, or an obstetrician can take a call on several measures to ensure that the baby is not born preterm. There can be some surgical interventions. There can be lifestyle interventions which can be done. No drugs, but some certain interventions that can be done. So that is one thing. The second thing we want to do is, see, in preterm birth is essentially like a time thing. It's like if you consider cancer is either you have cancer or you don't have cancer, or even COVID. When your RT-PCR test is positive, you have COVID or you don't have COVID. So it's an on-off phenotype, right? Here, it is based on a time, right? 37 weeks is up to 37 weeks. If a baby is born before 37 weeks, is preterm. After 37 weeks is normal. Who is to say that 36 weeks and 4 days is not is normal or preterm. We cannot say that right now. So it is more like there's ambiguity around the 37-week window, which we cannot really comment on right now. So one of the things that we are also doing is to actually classify preterm based on subcategorization of the kind of birth and the kind of features or clinical features that are present in the mother. So this is called data-driven identification of novel preterm birth phenotypes. Right? That's the first thing we are doing. Second thing, as I said, we are applying these machine learning approaches to develop an accurate and clinically useful model to predict and stratify women for the preterm birth risk, so that if we can tell the woman early, she can takes clinical steps, lifestyle steps to ensure that the preterm delivery is delayed as much as possible. And that's the end goal of the project. And this project is something that is about, like, we are still working on these 2 points. So at the end, I'll end the talk with acknowledgements. So as I said, this study was done at Translation Health Sciences Technology Institute, THSTI in Faridabad. The lead PI over there is Dr. Shinjini Bhatnagar. She is a pediatrician by training from AIIMS, Delhi. She is leading the study, assisted by 2 pediatricians, Dr. Ramachandran and Dr. Kondinya Desiraju, both at THSTI. At IIT Madras, my colleague, Professor Raghunathan from Chemical Engineering, and 3 of my students, Ashley, Nikita, and Ramya, worked on the 2 projects that I described today. We definitely would like to thank all the members of the Garbhani study team, which includes all the doctors and nurses at Gurugram Civil Hospital, Safdarjung Hospital, which was the sort of tertiary care hospital for us, and AIIMS New Delhi again was a tertiary care hospital. And finally, if none of the participants would have agreed to be enrolled in the study, this cohort would not have been successful. So these are actual pictures of the hospital. So these are the pregnant women who are coming in for enrollment. They are actually lining up for the blood test. And this is the data center where they're actually collating all the data. And these are all the data files, the paper record forms that are there. The study, this particular study at IIT Madras was funded by IIT Madras, Robert Bosch Center for Data Science and AI, and funds from my lab. The cohort, as I said, is funded, the Garbhani cohort is funded by Department of Biotechnology, Ministry of Science and Technology. The particular collaboration between THSTI and IIT Madras is funded by BIRAC, which is a Department of Biotechnology startup arm, and Bill and Melinda Gates Foundation. Thank you very much, and I'll be ready to take any questions.
Thank you so much, sir. We are now open for questions.
Thank you, sir, for the exceptionally informative session. I hope you all enjoyed this amazing talk. Now we can begin with the question answer session. So, sir, our first question is, how does the difference between the Caucasian and Indian population translate into the discrepancy between the Hadlock formula and the GARBH-INF formula?
Garbhani formula.
Garbhani formula. What are the factors adding to this difference?
Okay. So it's actually anecdotal evidence. There is no particular evidence, but if you talk to all the majority of the NRIs who are working in US and they have their babies born there, you would find that majority of the babies, if you look at the birth chart after birth of which is given by pediatrician to the parents, Indian parents, the Indian babies actually are what is called below the average line. They are progressing fine, but they're below the average line. So generally, Indian babies are slightly smaller. They are fully developed, but slightly smaller in size compared to the Caucasian babies. And also one of the problems with Hadlock formula was the Hadlock formula actually is a very, very, very narrow set of women that were taken. These were tall Caucasian, around like 5'8", 5'10", 6 foot women who had healthy diets and had accurate, so these women were planning to get pregnant and they were enrolled. They were enrolled before they were even pregnant. So they were enrolled and they were given a very, very defined chart to follow, right? So when you are doing that kind of study and developing a formula, you're developing a formula which is very, very narrow applicability, but it is one of the first formula. Therefore, it is the formula that is embedded in most machines. Whereas if you look at a general population, now if you look at Indian population, like there's a huge diversity, right? There, you have populations which are generally taller, you have populations which are generally smaller, right? So when you have such a large diversity, the errors would already creep in if you're measuring using a Caucasian formula. So that's the major difference why we see a difference in the gestation age.
Thank you, sir. Our next question is the data collected and then sort of put into ANN to improve predictability?
Put into what?
Predictability.
No, put into something you said. Oh, ANN. Okay. So see, we used CNN. Like I don't want to go into details here, but we use CNN, which is convolution neural networks for doing the study. But you cannot just take the data and put it into a neural network. You have to carefully figure out which methods would work on the data, because see, the problem with this kind of data is that this data has two kinds of data. One is numerical data. Numerical data is where you measure in centimeters or measure, let's say, blood glucose in numerical, CRL is numerical, head circumference is numerical. Then there are categorical data points, right? Smoking, yes, no, right? Alcohol, yes, no. Family income, like socioeconomic status, it has 5 categories, 0 to 5. Right? So when you have this diverse data, it is not just easy to input that data like that into a particular method. You have to actually transform the data before you can do that. So we did that. We did apply CNN and random forest ultimately, but it was after filtering the data, not directly plugged in.
Thank you, sir. Our next question is, does demography affect dating data like race, tribal, communal division, or can dating be a linear model that can be applied for all Indian women?
Okay, this is a very interesting question. So right now, as I said, this formula is based on a North Indian population which lives around Gurugram or Gurgaon. The next phase of this project, which is phase 2, which is already funded again by Department of Biotechnology, we are going to expand this study to eastern Haryana and bordering Rajasthan, as well as Assam, which means that we can now start testing whether the accuracy and the measurements that we took in the Gurugram population, whether they apply directly onto what we are measuring in other locations, or we have to modify a formula. So as I said, CRL formula is not going to change that much, right? We saw that as well because it's a single formula. The Garbhini GA2 formula, which is for the 2nd and 3rd trimester, that formula is a machine learning formula. So if we get more data, we can make that model refined, and that model can learn using more data, and that will become more and more accurate. So if we now start adding populations from different parts of India, so we are in talk with a hospital here in Tamil Nadu. We are in talks with hospital in Mumbai. We are in talks in hospital, as I said, in Assam, and again in north, in close to Haryana, Rajasthan border. So when we now bring in all those data points, the information from these pregnant women, our machine learning model will actually improve, and we hope that we'll be able to make what is called a pan-India model, which would be then applicable to all kinds of populations, subpopulations within India.
Thank you, sir. Our next question is, what are the causes of an infant being born overweight for gestational age?
What is the causes of infant being born overweight for? We are not, okay, that has, see, again, we are not trying to do that in the study, right? There are several reasons. Like, for example, gestational diabetes is one of the reasons why a baby can be overweight at birth, right? So we are right now, we are excluding those kind of women. And also okay, we are not testing for gestational diabetes in these women first. Second, we do measure the birth weight, but birth weight of the fetus or the neonatal baby is not a feature in developing this model. So right now we don't think it matters whatever the risks for high birth weight are, whether they affect the gestation age or not, because the last measurement we do is around 32 weeks, and most of the weight gain happens usually after that. That's what my understanding is right now.
Thank you, sir. Our next question is, what are the clinical signs of wasting of the soft tissues in a newborn infant?
Okay, that is beyond my expertise. I'm not a clinician by training. So if there is any doctor here, they can maybe answer that. But again, this is sort of beyond, we are not actually working with those kind of babies. That's why the reason we had to discard majority of the, as I said, right, we enrolled around 30,000 women, and we are only using data for 8,000 is one of the reasons why we actually removed several of the women, because of all these other complications. So these are as normal pregnancies as one can actually collect. So absolutely no idea what could be the reasons for that. That's a sort of a question for a pediatrician maybe.
Our next question is, what are the common complications of preterm infant?
Now, as I mentioned, right, so preterm babies have a high risk of death at birth or soon after birth. If they do survive, they have high risk of several infections, lung, respiratory problems, cognitive problems. They also have high risk of diabetes and hypertension. So there are several complications. And it all depends on how well the care is taken for the baby, right? So for a preterm baby, if the baby is 36 weeks or less, they usually need a neonatal ICU. So that's one of the reasons why Government of India really wants to understand what are the reasons for preterm birth and how one can actually mitigate that problem by studying these women, or doing these cohort studies.
Our next question is, many women in India are malnutrition during pregnancy, or due to morning sickness, they don't eat as much as they're supposed to. This could also affect the baby growth. So can this skew the data?
Good question. Yes, many women are malnutrition. So as I mentioned, morning sickness is only present in the first trimester, and first trimester usually the organogenesis is happening. So as long as the mother is well nutritioned in the first trimester, it doesn't really matter for organogenesis, but surely nutrition plays a very important role in second and third trimester. And there's a feature that we do measure in the study, which is called fetal growth restriction, which is we know what should be the average weight of the baby, and if the weight of the baby is lower than that, and that is measured by estimating the abdominal circumference that I was talking about. So if the abdominal circumference is below normal, we estimate that baby to be malnutrition, and usually those babies are high risk for preterm birth, right? So this can skew the data, but then what we have done is that we have excluded fetal growth restricted babies in the study, and we have in the study when we develop the model, but when we test the model, we don't really exclude anybody. We just take the normal population and we test it. So the robustness of the model is actually based on what is called the normal population, which has all these fetal growth restrictions, nutritional deficiencies in mother, and all those things are there. So we know that this formula is working fine. We are not filtering any woman in the test data that we are testing this formula on. But yeah, it can skew the data. But as I said, for model building, we do remove those kind of mothers that are having nutritional deficiencies, because we are measuring their blood profile, so we know if they have any blood related like nutrition deficiencies from their blood profile.
Next question is, what is the difference between ANN and forest method? Which one is more accurate?
Okay, I won't be able to explain all the difference between ANN and random forest. I did mention how does random forest work. ANN is slightly different. It's a neural network. So it's slightly complicated to explain for this audience. But which one is more accurate depends completely on what kind of data you're working with. For some data, ANN works fine. For other data, random forest works fine. For us, random forest work fine, better, not fine, work slightly better than the convolution CNN or ANN method. So it completely depends. So most of the time, people do apply large number of methods and see which of the method works best. And the one that works best is usually reported. So for us, it was random forest.
Next question is, what was the criteria for feature selections? What criteria decided whether these features were important or not?
Okay. This is again a very mathematical question. So as I don't know if you remember in the slide I showed, there were two methods that we use for feature selection. One is called generalized linear modeling, where we try to divide the data based on the feature, presence or absence of a feature, and ask whether the difference between the two is significant or not. That's one method. And the other method is called Baruta, which is again a random forest method. And in this method, we actually apply the same random forest modeling that we do that we use for the development of the model. So we actually ultimately use the random forest Baruta model to find which are the important features. So it's like giving an analogy for your Sanjay Gandhi National Park, right? Now, if there are certain landmarks so if from one end of the forest you have to go to RML colony, let's say. Now, there are several ways you can take, but there are certain landmarks along the way which if you follow, you will definitely reach the colony, right? Now, how do you identify that? So as I said, you send 10,000 students, let them figure out. So all the ones that use those landmarks to reach RA colony the earliest, let's say, or reached RA colony, there was, let's say, a time limit, right? You said, okay, reach by 5 p.m. You start at 9 a.m. All those are reached, you ask them, what all did you see? And they tell you these were the landmarks. Those are the things that we have actually sort of listed as the feature. So these are the features that if you include, you will be able to measure the gestation age more accurately. That's how we use it. That's how the criteria is decided. It's the ability, the frequency at which it comes, and the ability for it to high frequency then being causal for its ability to actually predict.
Our next question is, if there are any abnormalities in the babies like fetal hydrocephalus, would this data be also taken into account during standardization of data, or can this dating methods also be used for babies that are not anatomically normal?
Good question. Right now, as I said, these babies were as normal as possible. But as you said, there can be congenital defects in the babies, abnormalities in the babies, which can affect the dating and which can affect the birth. So generally, if there is a scan called fetal well-being scan done around 22 weeks. So fetal well-being scan actually looks for these kind of abnormalities. Now, if the clinician, radiologist or gynecologist identifies that a particular woman is carrying a fetus which has these abnormalities, that is considered as a high-risk pregnancy. And there are several options available to the woman. So if the scan is done before 22 weeks, one option is abortion, right? If the abnormalities are, like, for example, if there is microencephaly, right? Microcephaly. That means the brain is like Zika virus causes that, right? So if there's microcephaly, there is a very good chance that the baby born, even though born, will not be able to survive after birth. So a woman or a family can take a call on whether they want to continue. That's so anytime there is a high risk, like a developmental defect, there is a high risk. There is, if all the scans are done and sort of information given to the woman before 22 weeks, abortion is one option. Then there are other options, like you can, if they want to continue, they can continue, but then they would require continuous monitoring, right? More frequent monitoring, because it's a high risk, and high risk can be the pregnancy can result in stillbirth, can result in preterm, can result in normal term, whatever. Then it's not a ball game that we can actually use this model to predict anything.
Our next question is, what can a common man do to help in development of data to help the scientists develop better aging methods?
Oh, use this formula first. We are in discussions with various clinicians to sort of implement this formula in the clinic. That's the first thing. It should be actually this question asked by Sanika. It should be, what can a common woman do? The man doesn't have any role to play usually, right? So what can a common woman do to help in data? So yes, sort of as Dr. Nabi was saying, like, just keep good nutrition, like better aging methods. I don't think that can be done by, like, it can be crowdsourced. We are developing a method where we are going to what is called a prospective study, where we actually would track women who are planning to get pregnant and then see what happens there. So hopefully we'll be able to improve the method. But right now there is no way we can actually generally ask women, because you see, one has to understand this is a very very difficult study to do. Reason are various in India. First, pregnancy is not something that is pregnancy just happens, right? No, usually majority of the women in India do not plan pregnancies. First. Secondly, all the measurements that you do in a particular woman, right? So when we say we are going to give you standard care, like the standard care is first trimester scan, second trimester scan, blood samples every 2-3 months or something like that. If you deviate any time from the standard care, it raises an alarm bell in the mother and the family that there is something wrong. That's why the doctor or the gynecologist is asking me to do an additional test, which is not done for the neighbor's wife, for example, right? You are living in a village or a rural setting, you and all the old women know each and everybody's pregnancies, right? So they know that none of the other women got this test done, and this doctor is asking this woman to get this test done. So that's a challenge. You cannot ask any woman to do anything. So asking common women to do certain things is very difficult. Secondly, there is that, like, I don't know if you've seen, I don't know what's the status in Mumbai, but at least in North India, where we did this study, what was very surprising for me, at least, maybe it's not surprising for the doctors, is that when you're asking, so every woman that is enrolled is asked a questionnaire. So you have to fill in a form. There's a person who can fill in a form on your behalf. You just give oral answers. So for example, a woman is asked, do you drink or do you smoke? Right? A pregnant woman, right? So she's a daughter-in-law. She's come either with her husband or with her mother-in-law. And the mother-in-law or the husband is sitting in the next chair in the same room. I can challenge any daughter-in-law will say in front of her mother-in-law that I smoke or I drink, right? Especially now when she's pregnant. So all the answers were no for us, which was very surprising in Haryana, because we know for sure many women smoke, many women drink, but the answers were all no. For the 30,000 women was all no, which was a surprise. So We don't have methods to collect the data very accurately. That's the first thing. We also have challenges of public health where we cannot approach women prospectively, right? You cannot go and ask a woman, are you planning to get pregnant? That's a private question, right? You cannot ask. So what do? So it actually hats off to all the women nurses or the Anganwadi workers who actually are being enrolled in the Assam and the North, the sort of Western Haryana study, who are going to actually ask this question, right? Which is going to be a very challenging study, because you're going to ask a woman maybe very early enough, right? One of the ways we are planning to target is to visit all the sort of send Anganwadi women to houses which have marriages done, right? Because what we know in India, pregnancies, the first child is usually born within between 10 to 12 months after marriage, first child. So prospectively, you can actually start sort of tracking them. So these are the ways. So public can help, but it's a very challenging help. It's not like any disease. There are a lot of taboos associated with it. There are a lot, especially with the fact that if you ask any extra questions from the women in front of the mother-in-law or the father of the baby, the risk becomes is that they would start suspecting something. And if the suspicion goes that if the fetus is a female fetus, in several states in India with female infanticide being very high, that can lead to problems. So we really have to be very careful when we want to involve public in these kind of studies. That's my answer. And that's my understanding as well, which was an eye-opener for me. I actually thought that it'd be easy, but it's not.
Thank you, sir. Our next question is, how is LGA or large gestational age treated?
Okay, so once usually in our data, we only had 25, 30 pregnancies which were beyond the 40 weeks. And usually they are induced. So I think like clinicians can tackle this question more accurately, but you would induce contractions, right? You will induce contractions. You will then either do C-section, because if the baby becomes too big, then it's difficult to do natural delivery, because the head size would be too big, and that can lead to vaginal canal tears, which anyway happens during normal term birth as well, but there's a higher risk also. So there's a risk of bleeding, risk of placental rupture. So usually the women would get they would induce labor pains using, I think, oxytocin, if I'm not wrong, and or they would do a C-section. So there is no way you allow the pregnancy to go beyond 40 weeks generally.
Thank you, sir, for answering all our questions. Now I would hand over to Siddhant to propose a vote of thanks.
Good afternoon, sir. On behalf of Sapphire College, I would like to extend this vote of gratitude to our esteemed guest, Dr. Himanshu Sinha. Being a part of this session was truly an enlightening experience for us all. Your achievements speak volumes of your profound knowledge, and we are fortunate enough to have a glimpse of that today. The session was definitely a treasure trove for anyone who possesses even a bit of affinity for developmental biology. And the work that the Garbhini cohort is doing it deserves a special applause. The potential for applying this biostatistical prediction model in interventions is really immense. I'm sure it has appealed to the critically thinking minds of a lot of people present here today. We also want to thank you, sir, for answering our exhaustive questions. It only motivates us to learn more. Thank you for your patience. Once again, we thank you for addressing this session, and we wish you good luck with your future endeavors. Thank you.
Thank you very much. Thanks to all. Thanks for being patient listeners as well. Thank you.
Thank you so much, Siddhant, and thank you to you, sir, as well. We request our audience to please fill in the feedback form, the link to which is posted in the chat box.
Bye, everyone.
We will now move on to the next part of the event, that is the poster presentations. We know that art is an irreplaceable way of understanding and expressing the world. Through these posters, let us raise global awareness on the issues of maternal and newborn safety, particularly during childbirth.
Pregnancy. The word itself is enough to bring a smile on our face. The very thought of a new life entering our lives is more than enough to throw a grand party. But with all this being said, the most crucial part is the healthcare during pregnancy. First and foremost, a pregnant woman needs to have proper mental health care. It's vital for the mother to be surrounded with a positive environment for the proper development of the fetus. A proper nutritious and vitamins enriched diet is a must. Unhealthy and junk food is a big no no. Use of caffeine should be limited. Supplementary to this, a soon to be mother can take the vitamins prescribed by the doctor. Regular checkups is the most vital part of the routine. In order to keep in check the proper development of the fetus, follow ups are extremely important. Staying active is a must. With the proper guidance and instructions from the doctor, a pregnant woman needs to stay fit. Yoga is an excellent form to maintain flexibility. One more advice given to pregnant women is to read good books. The mood of the mother affects the fetus. If the mother is mentally happy and contented, it will have a positive effect on the fetus. Also, it is prescribed that a pregnant woman should be kept away from negative and stressful situations, which in turn can have a negative effect on the health of the mother and the fetus. And last but not the least, proper amount of sleep. With at least 8 to 9 hours of sleep, it is necessary for the fetus and the mother to get enough rest. Thank you.
Ending preventable maternal death must remain at the top of the global agenda. At the same time, simply surviving pregnancy and childbirth can never be the marker of successful maternal health care. Quoted from WHO's website. Maternal health refers to the health of women during pregnancy, childbirth, and the postnatal period. Maternal care in each stage should be such that women and their babies reach their full potential for health and well being. My poster lists a few basic but important points referred from Brigham Health Hub's website to help women have a healthy pregnancy and a healthy baby. Plan the right time to get pregnant. Women should not only make sure that they are healthy but also consider their age before getting pregnant. Women getting pregnant in the late teens or later in life, mid 40s, are likely to have premature babies. The period between two pregnancies should also be considered. Eat healthy. Good nutrition is especially important for pregnant women to ensure that the baby grows healthy and strong. Stay hydrated. Pregnant women's body need more water than it did before. Staying hydrated is essential. Get moving. Daily exercise or staying active in other ways can help you stay healthy during pregnancy. It is also important to get proper sleep and rest. Taking supplements help women get the right amount of key nutrients. Avoid. Reducing stress is crucial for improving birth outcomes. Certain foods like raw meat, raw eggs, soft cheese, unpasteurized milk should be avoided. Alcohol and smoking should be strictly avoided. Lastly, go to your prenatal care. It is essential.
Hi, my name is Taiba Qureshi, and our topic is safe maternal and newborn care. Every woman's body was designed in such a way that she could deliver her baby in natural way. Normal delivery is possible if a woman takes right care of her health during pregnancy. Here are some health tips for pregnant women. Work regularly on the mild exercises that are taught in the prenatal classes. Throughout pregnancy, exercises not only help to build good stamina but also keep you active. Maintain a healthy diet. The right nutrition makes you stronger and nourishes your body, which makes you capable of facing challenges of labor easily and comfortably. Refrain from stress. This helps to reduce the production of oxytocin, a hormone which is responsible for contractions during labor. Get adequate sleep. Practice right breathing techniques. During the process of delivery, a woman needs to hold their breath from time to time. So it is better to start breathing exercises as early as possible. Drink plenty of water. Have a plenty of water during pregnancy and make sure to drink at least 8 to 10 glasses of water daily. This helps to prevent urinary tract infections which pregnant women are prone to. Avoid caffeine as it increases your blood pressure and heart rate, both of which are not recommended during pregnancy. Measures to be taken during and immediately following childbirth. Follow the progress of labor and pay attention to danger signs that indicate help. Reduce the risk of infection by keeping hands, instruments, and delivery area clean by using gloves at appropriate times. Encourage the women to walk during the first stage of labor and support a choice of position for birth. Cut the umbilical cord at appropriate moment and care for it. Care for the baby and keep her or him warm after birth. Guide the mother to put her baby on her chest for immediate skin to skin contact and initiation of breastfeeding soon after the birth. Handling a newborn. Wash your hand before handling your baby. Support your baby's head and neck. Never shake your newborn, whether in a play or in frustration. Massage regularly as it helps in blood circulation and digestion. Hence, pregnancy is a wonderful combination of gain and pains. Thank you.
Hello everyone, my name is Saishri and I am going to tell you about maternal care and safe childbirth. The mother should eat varied and balanced diet. Eat plenty of starchy food to help relieve constipation. Eat plenty of calcium, protein, iron and various things. Drink lots of water to stay hydrated. Be aware of good kitchen hygiene and standards. Take folic acid supplement up to 12 weeks. Exercise. See if your GP See if your GP if you are uncertain about the amount or intensity of exercise you should be doing. Do pelvic floor exercises. It's never too early to start these. Be sure to book in with the midwives. They'll get the ball rolling with antenatal classes. Visit the dentist and other doctors for your health checkup. Get enough sleep and rest when you can. Have afternoon naps and go to bed at decent time. There's a small chance of some foods could be harmful to your baby, so get to know the list of foods that you should avoid during pregnancy, including certain cheeses, unpasteurized dairy, sharp and etc. Be sure to cut alcohol for the duration of your pregnancy. Limit your caffeine intake. If you haven't already, now it's time to quit smoking. Try to avoid X-rays during pregnancy. Avoid hot baths, sunbeds, and anywhere where there is a chance your body will overheat. In the heat, try to stick to the shade and be sure drink to plenty of water. Avoid people who have infectious disease. Your immune system is lower when you're pregnant. Avoid painting and decorating products, bug sprays, and pesticides and beauty products containing retinol and Accutane. It is also important to let labor begin on its own. Normal pregnancy is better. Walk, move around, and change positions throughout labor. It helps uterus more efficiently. Bring a loved one or friend for support. It encourages us. Avoid interventions that are non medically necessary. Avoid giving birth on your back and follow your body's urge to push. Keep your baby with you. It's best for you and your baby and breastfeeding. Skin to skin contact during the first few hours is very important.
Greetings, myself Sharanya Datta is going to present on an essential topic about the safety measures taken for the maternal and newborn. So, to contribute, let's start with some of the measures mentioned here. Proper intake of the prenatal medicines and healthy diet can have the increase of the maternal health and the newborn health, so to have a healthy pregnancy free of complications. Second, labor should take place according to the in-body contractions for a safer delivery. Maintaining a proper physical health by doing exercise may have a lot of benefits like fitness, childbirth, and occurrence of labor on time, better circulation of blood, etc. Avoid some of the bad habits which can be harmful for the child development, like intake of alcohol and cigarette can have a serious effect on the child development. Lastly, the practice of introducing the baby to the breastfeeding action helps the newborn to develop antibodies for any kind of diseases and can help in its development without any biological obstacles. Thank you.
Babies of mothers who do not get parental care are 3 times more likely to have low birth weight and have birth complications. Seeing the doctor regularly helps to ensure the mother have the healthiest pregnancy possible. Yoga reduces the stress and anxiety, increases the strength, flexibility, endurance of the muscles needed for childbirth, decrease the lower back pain, headache, shortness of breath. Pregnant lady needs more water than the average person in order to form amniotic fluid, produce extra blood, build new tissues, carry nutrition, enhance digestion, and flush out waste and toxins. Lack of sleep during the pregnancy has been tied a number of complications, including preeclampsia, a serious condition that affects mother's blood pressure and kidneys. During pregnancy, growing baby gets all necessary nutrients from mother. Mother's body uses vitamins, minerals, and other nutrients in food to strong and healthy vitamin that is important for pregnant women, may help to prevent major birth defects and fetus brain and spinal.
So poster talks about few practices of the maternal care. You have to visit your healthcare provider. They will do certain tests and then we will figure out how many weeks pregnant you are based on physical examination and also the date of your last period, or he or she will also use this information to predict your delivery date. If you're healthy and there are no complicating risk factor, most healthcare providers will want to see you in 4 weeks or in 2 weeks or also once a week until delivery. So talking about the nutrition and supplements, now that you are eating for 2 or more, this is not the time to go on a diet or cut some calories. In fact, it's just the opposite. You need to eat about more than 300 or 400 calories a day. And then if you are very thin or very active, so you have to eat more. But if you are overweight, your healthcare provider will advise you to consume fewer extra calories. Try to maintain a well-balanced diet that incorporates all the dietary nutrients like lean meats, fruits, vegetables, whole grain, low-fat dairy products. By eating healthy, balanced diet, you are more likely to get the nutrients you need. But you will need more of the essential nutrients like especially calcium, iron, and folic acid. Talking about the exercise, the US Department of Health and Human Services, they recommend that we have to work at least 2 hours and 30 minutes. Often even we can do an activity, or if you're not already highly active or doing vigorous intensity activity, so you can also do it for little time, but you have to do it. And being hydrated and taking fluids is important. To drink plenty of fluids, especially water. A woman's blood volume increases dramatically during pregnancy, and drinking enough water each day can help prevent common problems such as dehydration and constipation and so on. Taking rest is a must, and there are some rules for sleeping, like position. Some doctors specifically recommend that pregnant women sleep on the left side because one of those big blood vessels is on the right side of your abdomen. Lying on your left side helps keeps the uterus off it. Lying on your left side helps blood flow to the placenta and therefore your baby. So from the first week of your pregnancy to the 40th, it's important to take care of yourself so you can take care of your baby, even though you have to take some precautions and be ever aware of how what you do and don't do may affect your baby.
Childbirth can be extremely tedious and challenging. There are several aspects many tend to neglect which can affect the health of the child and the mother. This poster is a representation of some of the critical aspects that one must keep in mind before and after childbirth. Such a list of criteria, if followed appropriately, can ensure a secure development of fetal health as well as overall well-being of the mother. This poster also highlights challenges that a woman encounters after birth. These challenges can be harsh, but a very precarious approach should be taken. A gist for such an approach and challenges is highlighted here in this poster.
My name is Anfal Khan and I will be talking about maternal diet and nutrient requirements in pregnancy. Diet and lifestyle are important determinants of health of both mother and offspring starting from the preconceptual period. The consumption of a varied and balanced diet from the preconceptual period is essential to ensure both maternal well-being and pregnancy outcomes. However, the risk of inadequate intakes of specific micronutrients in pregnancy and lactation is high even in the most industrialized countries. Moreover, the risk of not reaching the adequate nutrient supply is increased for selected groups of women of childbearing age, those following expulsion diets, underweight or overweight, obese smokers, etc. The caloric requirements for healthy normal weight women with a moderately active lifestyle undergoes a moderate increase during pregnancy, which can be met by slightly increasing energy intakes in a balanced equilibrium between macronutrients within the recommendations of nutritional guidelines. Excess of calories and micronutrients during pregnancy may in fact be just as damaging as the deficiency. Some of the micronutrients and energy supplements that can be intook include proteins, fats, DHA, etc. During pregnancy, micronutrient requirements also increases more than those of macronutrients, and inadequate intakes can have significant consequences for both the mother and the developing fetus. In particular, there is evidence to support the psychological role played by selected minerals and vitamins. Um, Take of iron, calcium, vitamin D, folic acid should highly be increased during the pregnancy stage. Note should also be taken to focus on conditions associated with nutritional deficiency. For example, the recommendation to abstain from smoking in pregnancy is mandatory because of the increased risk of preterm delivery and low birth weight of the infant. There are some women that also exclude certain diets, certain nutrients entirely from their diet, and that is a huge risk and should certainly be excluded. The high prevalence of obesity in the general population and therefore in women of childbearing age increases the risk of complications in pregnancy as well as of infants with high weight at birth and predisposed to obesity in earlier life. A careful assessment of the nutritional status aimed at optimizing the dietary intake of micronutrients and at planning fortification is particularly indicated for women who experience repeated pregnancies, especially in case of multiple pregnancies separated by short-term periods, which increase the risk of depletion of maternal reserves. Very hard scientific evidence supports the importance of lifestyle and dietary habits during pregnancy and breastfeeding for the health status of women and their offspring. The consumption of a varied and balanced diet from the preconceptual period is essential to ensure maternal well being and favorable outcomes of pregnancy.
I would like to start off by saying there is no exact and one definition of motherhood. This is because being a mother is accumulation of so many things, a combination of experiences, emotions, hopes and dreams of her child. Motherhood is the most sacred journey that one has to travel in life. Certainly it has its own path, but greatly it is still rewarding at the same time. Motherhood is a state of being a mother. As a mother, there are a lot of sacrifices. To name a few, when raising a child, merely focusing on birthing a child from her own body. Someone who cares and nurtures her child with the deepest of love. Aside from being a mother means she sees the truest and deepest in her child. And most of all, she cares for the dreams and successes of her child. Your mother is a coach, a trainer, a cheerleader, and most of all, your all-time favorite fan. Besides that, she makes a place for you. Being a mother is one of the most difficult jobs, 24 by 7 duty, because it marks a new chapter in one's life journey. Motherhood is wiping down the kitchen, preparing snacks, cooking meals every day, cleaning up messes, cleaning the floor, wiping running nose of sick babies, drying tears of toddlers, washing the dishes, and doing all the household chores as long as she can. She's the one who gives us so much of cuddles and kisses, as well as never forget the late night snuggles. She never forgets a good day, so she can watch you playing in the sand and dirt. She ensures you enjoy the family vacations and reunions and the never-ending road trip conversations. Its wishing would never end. In the most simplest of words, being a mother means looking into your child's eyes and you see nothing but love. Patiently, you watch them grow and evolve with their own unique qualities. We as children always take our mother for granted, but without her, our life becomes worthless. A mother is a precious gift by God, which we need to keep with love and care. As it is said that God could not be everywhere and therefore he made mothers. The first teacher is a mother for any child, and if he or she keeps learning life's lessons under her guidance, nothing can stop him or her in achieving the heights of success. And lastly, I would like to conclude by saying that being a mother is someone who can take the place of all others, but whose place no one else can take.
Unquestionably, all of the posters were very gripping. Kudos to all the participants. Well, that wraps up our afternoon. On behalf of Sophia College, I would like to thank you all and our guest speakers for making time in your busy schedules to join us here this afternoon. We sincerely thank our principal, Dr. Ananda Amrit Mahal, our head of department, Dr. Shri Nair, other faculty members, and our coordinator, Ma'am Sukena Abbas, for helping and guiding us. We also acknowledge the support from DBT Star Status and all the students who have given their whole and soul to make this event a success. It's been a pleasure to host this event and wish you all a pleasant evening. Let's go orange and act now for safe and respectful childbirth. Just a reminder to please fill in the feedback form. The link is put up in the chat box. Thank you.